Dicen que el movimiento es vida y pues Regeneglobal es una empresa que está en constante movimiento. Parte de este movimiento ha sido renovación de laboratorios, ha sido actualización de los biotecnológicos que utilizamos, que comercializamos, que producimos, teniendo como resultado lo que menciona el video, una exclusividad en una producción de una estirpe celular que en la evidencia clínica y en la evidencia en laboratorio ha mostrado pues excelentes resultados. Pero nosotros no podemos tener resultados solos. Necesitamos médicos que nos ayuden a hacer la aplicación de lo maravilloso que nosotros hacemos. Por eso les doy las gracias a ustedes y a toda la comunidad de médicos Regeneglobal. Y para empezar este evento y antes de cualquier cosa, un enorme agradecimiento a todos ustedes que al paso de los años siguen con nosotros, que nos apoyan, y también a los nuevos que se van uniendo. Bueno, bienvenidos, bienvenidos a este equipo de personas que no queremos esperar a que haya medicina basada en la evidencia, sino que queremos crear la evidencia de esta medicina. Yo soy el doctor Alejandro Molina, director médico del corporativo Regeneglobal. Les doy una cálida y cordial bienvenida al día de hoy al evento que tenemos, que más que un evento, les diría que es un, un curso muy, muy rápido de una persona que tiene muchos años estudiando y haciendo aplicaciones clínicas, particularmente con las células Muse. Pero les quiero hablar un poquito del doctor Adeel Khan. El doctor Adeel Khan, si tuviéramos que definirlo de alguna manera, es un doctor justo que crea la evidencia. Sé que muchos de ustedes lo ubican porque atiende famosos, porque atiende a las estrellas, pero atrás de eso hay un médico em, que se atreve a hacer cosas. Es un médico que investiga sobre una nueva tecnología, una nueva técnica y se atreve a hacerla. ¿Siempre se tienen buenos resultados con esto? Pues definitivamente no. Y por cuestión lógica, pues no, vamos a tener casos buenos, casos no tan buenos, pero él ha ido perfeccionando. La vez pasada que platicábamos, él y yo, le decía, estás haciendo tu método CAN, ¿no? Para hacer las cosas. Y este método es conjuntar innovaciones biotecnológicas para tener un excelente resultado. El doctor Adeel Khan, que se especializa en rehabilitación y también tiene pues un montón de estudios y tiene un montón de experiencia, sobre todo en la aplicación de biotecnológicos, particularmente con células Muse, pero él hace más allá de eso. Y el día de hoy vamos a tener la oportunidad de que nos comparta ese más allá, ¿sí? Ustedes van a salir de aquí no solo sabiendo para qué sirve esta estirpe celular o cómo se usa esta estirpe celular, sino cómo se combina, cómo se dosifica, en qué pacientes sí hay evidencia de que funciona bien. Y esto va a ser muy importante para su práctica médica. Entonces, pues, bueno, yo podría quedarme aquí horas hablando, pero definitivamente no vinieron a verme a mí, vinieron a ver a alguien con más pelo. Entonces, sin más por el momento, los dejo con el doctor Adeel Khan. Démosle un fuerte aplauso y bienvenidos todos.
Hello? Yeah, okay, good. Okay, hi everyone. So thank you first of all for attending. It means a lot to me for someone who's been, on the cutting edge of regenerative medicine and seeing other doctors and healthcare providers who want to support our work because at the end of the day, we're all in this together, which is we want to make regenerative medicine mainstream. And ultimately, I hope the reason why you guys want to do that is for the same reason I want to do it, because it's better for our patients and it's better for society at large, right? If we can prevent diseases, if we can treat the root cause, or if we can actually reverse diseases, and instead of just managing symptoms, that's going to be better for everyone. So thank you, and hopefully you'll find this a very engaging kind of morning and afternoon. I'm trying to really just share my really life's work, I guess, with you guys here today in terms of what I've learned over the years. I've been fortunate because I've traveled around the world. I've worked in Japan. I've worked I've gone to China, to Europe, to obviously U.S. and different parts of the world with different scientists to kind of learn and put all this information together, and a lot of it was driven by the fact that you don't always get the results that you want. How do you keep improving, right? So I've tried to kind of continue to improve the outcomes for my patients, and that's what led me to the Muse cells. I'm sure obviously everyone here knows what the Muse cells are now, but with Regen Global, I had met Professor Dazawa in a couple of years ago, and no one really knew about her work, and I found that very surprising. And so I connected her with one of my patients. They started a MuCell company, and then I connected her with Regen Global, and now Mexico has access to MuCells because of that. So I'm very proud to be the one to help bring that to Mexico and to other parts of the world, and hopefully it'll help millions of people. But we'll talk a little bit about the science behind obviously MuCells and some of the other there's Dazawa MuCells, but there's also adipose-derived MuCells, which are made in a different way. And we can talk about that too, because I think it's always important to be unbiased as well. And that's part of the reason I try not to associate myself with just one, let's say, manufacturer or one type of brand. Obviously, there is different ways to make these type of products, and you have to remain objective. So we'll go into that. I guess just to get a show of hands for me to understand what are people's backgrounds here. So how many people here are doctors? Okay, and what are most of you? What are the specialties? Are you orthopedic surgeons, general medicine, dermatology? Okay, let's raise your hands if you're just general medicine. Okay, and then raise your hand if you're orthopedics or sports medicine okay, and then raise your hand if you're dermatology or skin or more of that, aesthetics. Okay, more of those. And then if you're some other specialty, I know there's an ophthalmologist here. What's your specialty? Ophthalmology? Oh, okay, so there's a few ophthalmologists here. What's your specialty? Internal medicine. Yeah, so we deal with we'll go into that type of stuff. Obviously, the ophthalmology is a very interesting application for this stuff, but this is going to be focused more on, I would say, general kind of, let's say, chronic complex disease, longevity, orthopedics. Those are going to be the main topics. And obviously,
Ortopedia, eso es lo que vamos. Y también incluso algunas aplicaciones cosméticas. ¿Había alguna pregunta por allá? ¿Perdón?
oh, immunologist. You're an immunologist. Oh, great. Okay.
Homóloga.
I love immunology.
Me encanta esta sección y vamos a platicar de ello también. Es uno de los temas más fascinantes cuando se trata de longevidad y el envejecer. Yo sé que ustedes ya están al tanto de ello, pero es uno de los temas que estaremos abarcando. Estamos planeando hacer una demostración en vivo por la tarde. Es más para ortopedia y mostraremos ultrasonido, cómo
the
utilizar.
technical aspect of that, because ultrasound, obviously you can't learn everything in just one day, but you can learn some of the clinical pearls that we've learned over the years in terms of what to look for, what to watch out for. For example, you have to be careful when you're injecting a shoulder, like a supraspinatus tear. Sometimes you can cause frozen shoulder, and how to avoid that and things like that. So there'll be a lot of little tips and tricks that we'll share in the afternoon. I have my radiologist here with me, and she'll be assisting me with that. So for people who are interested for that component, then obviously we'll dive more into that. So let's get into it. Is there the presentation? Oh, sorry.
Sesión 1. Estética regenerativa y longevidad basadas en la evidencia.
Yes. So this is kind of like an overview. I think the big thing too is, we'll talk about is measuring, because I'm sure you guys, regenerative medicine doctors, we get a lot of hate from a lot of academic doctors because they say there's no evidence and there's no science behind it. Obviously, there is a growing scientific base, but it is also important for you as a practitioner, if you're going to offer this to your patient, to be able to be as objective as possible too. And that's one of the things I've been trying to work on. And so I'll share some of the insights as to what you can use for that. So yeah, for longevity, and aesthetics, we want to talk about not just necessarily treating the superficial, right? It's about making the whole system healthier and younger, because ultimately then your outside will look better too. And we want to talk about cellular repair as opposed to just, as obviously I think you guys know, you guys are here for a reason, but a lot of people, Botox, obviously Botox is still going to be there. It's not going to go away, but a lot of people want to understand how to actually make their skin healthier or slow down aging on their skin and in their whole body. So in terms of the skin, just like any other organ system in your body, it has the same hallmarks of aging, right? The mitochondrial dysfunction. Are you guys familiar with the 12? Have you guys heard of the 12 hallmarks of aging? Raise of hands. Only some people? Okay, not everyone. So there's these 12 hallmarks of aging that have been published as kind of the reason why our body ages, and that applies to any organ system, including the skin. And so these 12 hallmarks of aging include mitochondrial dysfunction, something called SASP, senescence-associated secretory phenotype. There's telomere attrition. There's loss of autophagy or macroautophagy. So there's all these kind of mechanisms that happen, but the two of the most important ones, and the ones that I will talk about probably more over and over, is about mitochondria, and then also about stem cell exhaustion, because obviously that's one of the big focuses of what we're trying to do, is we're trying to increase the amount of stem cells in the body and get your own stem cells to work better. So the way we're trying to understand aging, and this is just to, again, this applies to everything, but since we're talking about the skin first, you might as well understand why does the body age in the first place? Does anyone know the leading theory on why we age? Telomeres, good guess, but not, and that was the old theory, but that's not the most correlated. So telomere attrition and shortening of telomeres, it doesn't have as good predictive power as we thought. And there's something else that's more important. Inflammation, I heard, or immune system, that's up there, but there's one more that's even more important. Which, did you say oxidative stress? Yes, that's right. So oxidative stress, free radicals, and it's not just as simple. It's because they've done animal studies where they have these animal mice models, and if they have more oxidative stress, some of them actually live longer. So it's not as simple as just more oxidative stress means you're going to live less long. So it's actually a bit more complicated than that. The actual root of it is what's called mitochondrial DNA fidelity. And this is basically your own mitochondrial DNA over time makes more mistakes. And there's something called polymerase gamma, which is basically an enzyme that helps to repair that mitochondrial DNA, and that enzyme doesn't work as well. And so that enzyme can't repair that DNA, and then you start getting these mismatches of base pairs, and over time, that's what starts leading to the aging process. So it's more than just oxidative stress, but ultimately, we do think the mitochondrial DNA is one of the biggest reasons as to why we age, which is why mitochondrial transplantation and mitochondria in general are a very hot topic in longevity and anti-aging. And that's why, with the stem cells, coming back to how we target the root cause, we understand that the Muse cells, one of the main mechanisms by which they work is mitochondrial DNA transfer. So they actually create little nano-tunnels. And then the mitochondrial DNA actually transfer that material to the host. And then they also do what's called mitophagy, which is repairing damaged mitochondria. So that's actually one of the really interesting mechanisms by which Muse cells and stem cells in general are helping to repair the body and get to the root cause of aging. Which is why this, I think this, for when it comes to aesthetics, we want to obviously understand. We're talking a little bit about the root cause as to how these cellular therapies are actually going to restore the skin and the texture and the quality. But I don't know if have people here used MSCs for the face. Yeah, and how did you find it? Did you see Exosomes and yeah. So, I personally, when I was using MSCs, when we were using them, we didn't see great results with the MSCs for the face. With the exosomes, we would see pretty good results with microneedling, but you'd have to repeat it pretty often, like every month or every 2 months. So for us, because I work in a very unique way where sometimes people are traveling from different parts of the world and you only really get to see them once a year or something, then I'm always trying to figure out, is there something that's more potent that can be effective for a longer period of time? Excuse me. So basically, what we do now.
Lo que hacemos hoy en día, y esto es uno de los mecanismos que causa longevidad. Estás intentando generar colágeno, verificar la membrana exógena. La manera en que lo hacemos es con una microaguja, ponemos exosomas en el rostro y después de este paso utilizamos mesoterapia. En Turquía se llama una pistola MP. Es la herramienta más rápida del mundo. ¿Y por qué? Porque lo inyecta tan rápido que lo hace menos doloroso. Y también utiliza inteligencia artificial para que ajuste de manera automática la profundidad, porque a veces hay resistencia, por supuesto, en la dermis. Entonces, quieres que las células sí lleguen a la dermis, y por eso necesitamos esta microaguja. Es una de las técnicas que utilizamos y personalmente siento que los resultados pueden durar entre 6 meses y un año. Claro que hay diferentes factores que afectan, pero no es tan frecuente como los exosomas. Las personas que están interesados en este enfoque cosmético, eso es lo que hacemos y he visto que sí entrega muy buenos resultados. ¿Alguna pregunta? Perdón, no escucho. Las inyecciones de plasma, sí puedes mezclarlas, no es un problema. Sí mezclamos PRP cuando hacemos, por ejemplo, diferentes inyecciones y necesitamos más volumen y mezclamos el plasma rico en plaquetas. Pero en el rostro no necesitas tanto volumen, a lo mejor tienes suficiente con el producto, así que normalmente no es necesario mezclarlo, porque obviamente cuando hablamos es decir, si comparas el perfil, el PRP con los exosomas o los secrotomas, se convierten en ello. Yo sé que del secretoma se va a convertir en exosoma y ellos tienen 1000 veces más factores de crecimiento y PRPs. Entonces, es muy ligero comparado. Si tu dosis, digo, al menos que necesites más volumen, yo no lo mezclo, pero si necesitas más volumen, hay alguna investigación que sugiere que la PRP puede ayudar a las células madres con estas variaciones. No va a causar daño. La dosis es importante. Hemos jugado con ello. Aquellos que no saben, yo fui el primero en utilizar estas células. Es algo que me dio la fama, me imagino, pero ahorita ya tenemos mucha publicidad, mucho marketing alrededor de ello. Hemos hablado mucho del tema, pero creo que yo fui el primero y debido a ello, pues tengo mucha experiencia. La dosis en comparación para el rostro, puedes utilizar 5 millones, eso es suficiente para la mayoría de la gente. Si quieres hacer más, puedes llegar hasta 20 millones. No es una cantidad muy, pues muy loca por decir algo.
And then the other thing too is there's less likely to have reactions and things like that, because obviously when you have more cells, there's always going to be more risk of reactions. And I think and then usually we use 100 billion exosomes, 100 to 200 billion exosomes at the same time. So just to give you a reference, when we do IVs for like longevity, for a lot of times it's 20 million, and that's for the whole body. So imagine you're putting 20 million just in the face. You're going to have a pretty strong effect, you know? So for like a lot of our celebrity clients and people who just are like, you know, we've actually even done, I mean, I don't recommend this, but we've even done 100 million in the face. But, you know, that was for like the Kardashians and people like that. They're just like, and that's, but it doesn't, I don't, and, but if I'm being honest, I don't really know if doing 100 million a face made a big difference compared to doing 20 million. You know what I mean? Like it was more cells, but I don't think it really, at least from what I can tell, it doesn't, the effect is the effect. And I think the rest of the cells just migrate, you know? So yeah, so just like any, you know, chronic process, and the skin's to me is also very interesting because it's the I mean, arguably fascia is our largest organ system in the body, but maybe skin is the second largest now based off of, you know, most recent research. But the skin also is like an immune barrier for your body, and there's research that this one group is doing, for example, where they found. Do you guys know what senolytics are? Senolytic, like to remove zombie cells in the body. So there's this company developing a peptide senolytic, and they have it in a topical form for the face. And they found that when they applied it even just to the face, that they found this was done. This is just early human data they have. They've already done it in animals, but when they did it in animals, and then now they're starting to do it in humans, what they found was when they just did it for the face, that they found that there was actually a systemic rejuvenation effect in the body just from applying a senolytic to the face, and which is really interesting because it's just basically getting rid of some of these senescent or zombie cells, and it can actually make your whole body potentially younger. But of course, you can apply it to different areas. But it's a really interesting product. I think you'll see it probably come out in the next year or two. But they're in their early kind of clinical phase data. And yeah, you know, for I think I guess the big thing to understand about the mechanism is when you're doing the microneedling, you're inducing inflammation, right? And so, which is actually good because Muse cells like inflammation. Which is what makes them different from MSCs. Muse cells home in on inflammation, and they're what's called stress-enduring cells, as you probably know. So meaning they can survive in those harsh environments, and because of that, you're actually facilitating their ability to do their job. And so at the same time, if you really want to, let's say, maximize the therapeutic effect, you can also do an IV at the same time as the face or hair treatment. And then that way you're getting some of the Muse cells potentially going to the face or hair via the bloodstream too, because you've induced some inflammation. So that's, you know, for people obviously who are trying to maximize the cosmetic aspect, that's kind of like the, you know, let's say full package that you could do for them. Yeah, so regeneration requires a scaffold. That's a interesting, you know, that's kind of what I want to highlight here. So does anyone know the three foundational pillars of regenerative medicine? So it's cell therapy, gene therapy, and tissue engineering, right? So those are the three things that are going to kind of lead us to the next era of medicine, and combining those in different ways, obviously. So tissue engineering, of course, we're not fully there yet, but the one thing we do understand is that if we want to have optimal regeneration, having some sort of scaffold is going to potentially lead to better results. And, you know, so we'll talk more about that with the orthopedic, but there is a company that we've been talking to that can encapsulate the Muse cells into a hydrogel, and then basically so that when you inject it into the face, it'll stay where you want it to, as opposed to, because a lot of them are going to migrate, right? So that's going to be, you know, that's going to be an up and coming therapy, and that's something hopefully we can offer with, you know, Regen Global. Regen Global has always been really good with my ideas and my new, you know, whenever I have something that I want them to make, they usually are good with that. So hopefully that'll be something that Regen Global will offer in the foreseeable future, because that to me will be a better option than just injecting the cells without a scaffold. You know, there are kind of these other type of hydrogels out there now too. A hydrogel, for those who don't know, is kind of just like collagen, like a hyaluronic acid, but then it forms a 3D scaffold. So as opposed to staying like a liquid, it actually has an encapsulation and actually works as a drug delivery system for the cells. So it's a bit more advanced than just hyaluronic acid. Yeah, so we actually did a small pilot study with this hydrogel company. The hydrogel we use is called arthrosomate. It's a brand name from Denmark, and basically the study was to see, do the Muse cells actually, like, number one, survive, and number two, actually still able to do their job, right? And they actually found that the hydrogel increased their metabolic activity, and then so even though you're injecting them into a small space like a joint, it actually may improve their viability. And there is a lot more research coming out about that, how hydrogels may actually improve stem cell delivery and survival. So yeah, I think so. I don't know, does that answer your question? Or yeah, okay. So yeah, so cells, signal, scaffold. That's kind of what we want, right? To actually have regeneration. And the cell, and so in the case of the face, the signals are the exosomes, obviously, and the cells obviously have signals too, or secretome. If you're using secretome, that's signals as well. And then the scaffold would be the kind of the missing piece right now that hopefully will be solved in the next 1 to 2 years. With these there's this really cool device that's coming out from this company called Lacarda. It's a hydrogel company. Basically, it offers. It's like a benchtop device, and you're able to essentially put your stem cells in there and have real-time encapsulation of them. So I think that'll make it a lot more accessible. And then I guess for people to, again, like with whether you're doing the skin or you're doing the body, you always want to try to prepare them beforehand. The main preparation to understand, the only thing I would say is with bruising sometimes. Obviously, there's dermatologists in here, so they could probably talk about it more than I can. But but we want to, for example, like getting them off omega-3 fish oil, because sometimes that may increase their risk of having bruising. And then the other thing too, what we do after the facial, we often recommend copper peptide. You can apply it both topically right after the facial, or you can obviously take it at home subcutaneously, and that's just going to facilitate collagen production and kind of the goal of this procedure, which is to actually get the skin to produce more collagen and make the skin healthier. So that's one of the kind of tools that we use in addition to the cells and exosomes. You can just microneedle it. So most peptides will not absorb through you can't do that with like BPC or like SS, but copper peptide can actually absorb through the skin. Yeah, so this is just in general, I guess, for people to again, I think it's important to be question?
Yes, just a quick question about the peptides. Do you use the one from the US or the one from here from Mexico?
Estados Unidos o el de México, debido a que tienen, sí, digamos que hay una compañía con la que yo trabajo y de forma transparente quiero decir que yo soy uno de los cofundadores, pero bueno, se llama Peptual. Y el motivo por el cual empezamos esta empresa es porque nosotros detectamos que había un estándar que era muy elevado, así que queríamos asegurarnos de que tuviéramos los ingredientes correctos, la secuencia de los aminoácidos que se elabora en Estados Unidos, y sabemos que también otras personas utilizan ingredientes de India, de China o de otro lugar. En este caso, pues bueno, a veces los compran en Estados Unidos y tienen que decir que son en Estados Unidos. Entonces es por ello que nuestros precios son elevados, pero también la calidad también es más elevada. Así que también tenemos un distribuidor en América Latina. Si están interesados, les podemos compartir esa información. Sí, exactamente. ¿Sabes? Entonces, esto es para que las personas puedan comprender. Por supuesto, cuando utilizamos las Muse cells, es una ciencia completamente nueva. Existen cientos de información de humanos que utilizan las células Muse y también pruebas clínicas también. Entonces, podríamos decir que hay muchos documentos con las MSCs y también con respecto a los exosomas, los secretomas, los diferentes tipos que hacen la diferencia y que conjuntan todo toda la información, porque bueno, pienso justo como habíamos dicho, está destinado para tener un equilibrio con base en la gran prueba que nosotros tenemos y también en este caso poder empujar esta barrera, porque no queremos ser este tipo de médicos, ¿saben? Que hacen en este caso que no tienen un respaldo de la ciencia, porque sabemos que hay muchísimos sí en en el campo. Así que bueno, esto es básicamente el modelo. Supongo que podríamos decir que me gusta dar seguimiento a todo lo que tiene que ver con el cuerpo, toda la parte sistémica, todo este tipo de suministro de este tipo de células y queremos priorizar, por supuesto, el cuerpo y también la reparación y el reforzamiento del mismo. Así que bueno, vamos a profundizar en cada uno de estos detalles. Bien, entonces supongo que antes de que continuemos con estos puntos, con respecto a la parte estética, porque antes de que abarquemos la parte de longevidad, también algo de lo que también estuvimos platicando fue sobre la parte capilar, el protocolo capilar, cómo tratar el cabello y el acceso a las células madre también. Así que bueno, básicamente, y por supuesto puede funcionar muy bien para la parte capilar y nosotros entendemos que lo que ocurre también con la parte del crecimiento, pues bueno, hay folículos debilitados. Y por supuesto existen pruebas con plasma rico en plaquetas, es decir, diferentes productos y la forma en la que nosotros lo hacemos es un enfoque bastante similar a las microagujas utilizando exosomas, utilizamos 100,000 millones o también 5,000 millones de exosomas al mismo tiempo y utilizar nuevamente, digamos, esta especie de pistola para poderlos aplicar, así que pueden tener múltiples sesiones, la frecuencia de ellas y la dosificación puede variar, por supuesto, pero de forma ideal, digamos que podrá ser una cada 4 o 6 semanas y que hagamos entre 1 a 3 sesiones con las células madre, así como con los exosomas. Y también, si digamos está dentro del presupuesto porque las células madres son más costosas, pueden también aplicar los exosomas y pueden funcionar muy bien. Así que bueno, estamos hablando de 3 a 6 o 9 sesiones para que podamos tener un resultado idóneo. Y en esos casos, pues bueno, lo que podemos hacer con los exosomas, pues bueno, hacer una reevaluación después de 3 o 6 meses y decidir si necesitan una serie de 3 sesiones más. Esto es lo que hacemos. Yo creo que es muy similar a lo que las personas hacen con el PRP, que digamos que no hay tanta diferencia. En este caso, digamos que los exosomas es una señal más fuerte para saber cuánto cabello se va a regenerar con este tipo de tratamientos. Estoy segura que, bueno, en este caso a lo mejor las personas ya han hecho este tipo de terapias. ¿Ustedes han observado buenos resultados? Los exosomas, ¿de acuerdo? Sí, exactamente, con las microagujas, ¿cierto? Sí. Sí, exactamente. El hecho de tomar suplementos también ayuda. De acuerdo, sí, exactamente eso. Se consiguen buenos resultados, así que a veces me pregunto si realmente se necesitan las células madre, ¿cierto? Porque yo creo que en lo personal puedo decir que podemos lograr el mismo resultado para el cabello sin las células madre. A lo mejor en este caso vas a necesitar más sesiones. Doctor, también usted mencionó que utilizan exosomas y células madre al mismo tiempo después de 4 o 6 semanas y también existen algunas pruebas que dicen que las células Muse probablemente se recomienden también de forma frecuente porque a veces no permiten, digamos, al proceso completo, al proceso de regenerativo con una sesión anterior y tal vez no pueda funcionar bien. Entonces, algunos estudios mencionan que tenemos que esperar o tal vez en el caso de los exosomas podemos hacerlo de cada mes, lo cual es ideal. Y también son diferentes métodos que se utilizan en la frecuencia de células madre, en la restauración capilar, en función de los protocolos existentes. Sí, exactamente, este es un buen punto. Y también existe información que también ha salido y del cual también me gustaría hablar al respecto. Y básicamente es cuando las células madre parecen, en este caso, se adhieren rápidamente, a lo mejor de 4 días, 5 días, podemos ver, o esto también ocurre mucho con el tipo de cuidado. Es decir, es como una especie de injerto que se hace y es el mecanismo que se aplica probablemente durante la primera semana. Podría decir que 2 semanas como una forma de precaución. Yo les diría, pues bueno, no se puede tomar durante 2 semanas. Estamos teniendo una terapia intravenosa porque, bueno, está circulando finalmente en el cuerpo y también tenemos información que ha sido publicada, que se han hecho prueba en animales, no sé si en humanos o si podrá hacer lo mismo, pero si, por ejemplo, hay como una especie de injerto rápidamente o digamos, adherencia rápidamente, entonces se sugiere que estaría muy bien repetir con más frecuencia. Y este es el motivo por el cual, si ustedes ven, por ejemplo, el estudio que se realizó en Japón con la EOS, viendo la frecuencia durante 6 semanas. Entonces, no sé si todos podamos saber en algún momento la frecuencia perfecta, pero con base en la experiencia clínica, yo creo que está muy bien dar un espacio de 4 a 6 semanas y esto está muy bien. Sí. Sí, exactamente. La parte sinolítica es muy importante. Es un tema sumamente interesante. La empresa de la cual yo les estuve hablando ha demostrado que hay un complejo sinolítico que me parece que hay de 80% con este tipo de células. Así que es un efecto sistémico perfecto en el cuerpo y me parece que es un tema muy importante y esto sin duda alguna nos da un desglose. La terapia todavía no está disponible. Así que en este caso sí contamos con los suplementos que tienen diferentes sinolíticos en las formulaciones y también en este caso se puede quitar, digamos, hasta el 20% de este tipo de células. Y hay una empresa que se llama Qualia, me parece. No sé si han escuchado, pero tienen una marca con suplementos sinolíticos y en este caso hacen que las personas le den prioridad a la terapia de infusiones 2 días antes. Y la lógica en este sentido es que, por ejemplo, las células sinolíticas puede conllevar a inflamación y las células en las que nos estamos enfocando pueden distraerse de la meta a la que tenemos. Entonces es por eso que se hace que tengan esta dosis antes de la terapia. Y también otra pregunta fue para los tratamientos capilares. ¿Han visto en este caso con base en el patrón de fusión? Sí, yo creo que les puedo mostrar algunas imágenes también que nosotros tenemos. Básicamente, hay algunos casos en el que son muy delgados, es decir, si no hay cabello, realmente no va a volver a crecer. Bueno, sí hubo un caso en el que sí se logró, pero bueno, no puedo decir que esto va a ocurrir siempre. Así que bueno, en general, si tienen cabello muy delgado, este método del patrón, utilizando este método podría funcionar muy bien. Pero también la clave también es muy importante porque la clave con esta condición es hormono, en este caso el THT. Y sí, puedes llevar a cabo el tratamiento, pero si no se bloquea el THT, pues en este caso va a retornar. Así que es algo que tenemos que tomar, algo que es la testosteride, es decir, captar estos receptores, porque de lo contrario no va a bloquear la testosteride. Se ha probado en Corea y es probable por el cual siempre recurrimos o siempre vamos a Corea en cuanto a epigenética. Así que bueno, es algo que podemos utilizar después del tratamiento para ayudar o para reforzar o asegurarnos de que el cabello no se va a caer nuevamente. Pero bueno, con el testosteride, decimos al cabo de unas semanas, es importante entender con la testosteride, la dosis es importante porque no es que lo tengamos que tomar día a día, se puede tomar 2 veces a la semana, ¿cierto? Así que no se tiene que tomar todos los días para mantener los niveles de THT bajo control. Sí, realmente cuando yo estuve trabajando, no puedo recordar la referencia correcta para pero no sé, ¿sabemos el rango de referencia con el que trabaja normalmente? Sí, exactamente. Entonces, este es el rango de referencia que se está utilizando, así que yo creo que es algo muy bueno por el cual se tiene que tomar la dutasterida con base también en el trabajo que se ha hecho. Entonces, bueno, esta es la clave y el detalle es que si se vuelve o que vuelve a crecer el cabello, pero si los niveles de THC es de 500, bueno, tenemos que dar seguimiento. Bueno, por supuesto que hay aspectos de longevidad que vamos a cubrir. No sé si hasta el momento hay alguna otra pregunta con respecto a la parte estética. Por supuesto, estamos hablando de la cara y el cabello, que quizá no es tan complicado, pero cuando hablamos, por ejemplo, de complicaciones o riesgos, yo no he visto nada de riesgo con, digamos, esta pistola que les comenté o el tratamiento con microagujas. Tuvimos un dermatólogo que estuvo trabajando con esto y que estuvo utilizando cánulas. No sé si ustedes ya lo han hecho de esta manera también. De forma, digamos, potencial o de forma efectiva, podemos decir si hay más voluminización, sí, pero con la cánula también. También podemos ver a personas que tienen reacciones inflamatorias y también tienen, digamos, pápulas también que pueden salir. Entonces, es algo que tenemos que vigilar. Si alguien, por ejemplo, siente que tiene un ganglio o, por ejemplo, una pápula que digamos que puede ser una reacción inflamatoria de las células, entonces se puede dar un masajito y puede desaparecer al cabo de unas semanas. Entonces, sí, por supuesto, también existen otros detalles que van a ser más complicados. La parte estética realmente es muy sencilla. No sé si hay, por ejemplo, otra pregunta. Sí, exactamente. Vamos a profundizar los tratamientos sistémicos. Usualmente utilizamos el 31 y el SS31 porque ayuda a estabilizar la cadena de transferencia y esto le ayuda a la mitocondria para que funcione muchísimo mejor y también ayuda a equilibrar el estrés oxidativo. Y nuevamente, debido a que las células Muse trabajan primera o principalmente en la mitocondria, pues bueno, tiene que controlar el estrés oxidativo y es por ello que logra este efecto. Realmente no lo tienes que hacer para el cabello, es para la piel en este caso. Tenemos los péptidos también, o también si realmente si son muy activos potencialmente, puede ser el PB3 o 4 y pueden recurrir a los péptidos también. Sí, exactamente. Por ejemplo, si vamos a utilizar un relleno con las células Muse, yo sé sin duda alguna es que ustedes están pensando en hacerlo de esta manera, pero por ejemplo, si yo utilizo un relleno, sí, exactamente, sí, hemos practicado con esto, se estaba utilizando el ácido hialurónico como un relleno para el andamiaje de ello, así que bueno, pienso que sí se puede, es posible y realmente lo que yo veo o puedo decir que los resultados son sumamente diferentes al utilizarlo de esta manera. Por supuesto, vamos a ver el efecto relleno, pero tiene que ser en una dosis más baja, pero sí podemos utilizar más andamiaje, sí, sin duda alguna. Pero también estoy pensando en este caso en realizar este tratamiento estético para hacer un levantamiento y que se pueda realizar con una cánula, aplicando las células Muse en otras áreas, en las partes que se van a rellenar. Entonces, ¿usted qué opina o qué tipo de resultados podríamos esperar a partir de esto? Bueno, sí, con la cánula definitivamente vamos a tener un efecto de levantamiento, vamos a tener más volumen o un aspecto muchísimo más estético. Así que, bueno, recuerdo que lo hice esto con una cánula y también con el relleno al mismo tiempo. Así que no sabría decir a ciencia cierta cómo sería el resultado, pero depende muchísimo del paciente. Si ellos quieren algo más inmediato, algo más notable, bueno, la cánula, la técnica con la cánula puede ser una mejor opción, pero también si están bien en este caso justo como les dice, ayudar con líneas finas o en este caso para recuperar o reparar la piel, bueno, pues también es una forma en la que lo podamos hacer también. Así que bueno, pienso o básicamente lo que estoy diciendo es que la cánula, ambas son buenas opciones, pero la cánula puede haber más más riesgo, como te decía, tocar un ganglio o en este caso que pueda haber un proceso, digamos, inflamación, pero con el uso de la pistola no he visto este tipo de reacciones. Entonces, para hacer levantamiento en un área temporal, no sé, bueno, ¿tú te refieres a la cánula? Sí, es correcto. Ok, muy bien. Exactamente. Muchas gracias. Muy bien. No sé si tengamos alguna otra pregunta. Sí. Tenemos algunas preguntas con respecto a los médicos que están en línea. Doctors, I would like to ask you if you can wait for the microphone
Y
because
ellos
we
no
have
alcanzan
so
a
many
escuchar las
doctors online
preguntas
and
y
they
también
cannot hear the
en un
question.
futuro ustedes ven la grabación, pues no tendrá sentido porque no se va a escuchar lo que estamos todos preguntando. Pero tenemos una pregunta en línea. Nos pregunta la doctora Elizabeth Itumabelín. Dice, about the aging for GLP-1, what amount of cells and how often you will recommend?
GLP-1?
Yeah, about the aging that for the use or the abuse of this GLP-1 in the face, in the skin.
Well, I'm sure you guys have heard of Ozempic face, right? Like
Yep.
people, so that's a problem
Sí,
with the
yo creo que este
GLP-1.
sería un problema con los
And
GLP-1.
there is some research.
Porque hay
One of my colleagues
investigación,
had
si uno
published
de mis
something,
colegas
you know,
ha
if you combine
publicado algo, es
so if you
decir,
put someone on
si
a
ponemos
GLP-1 and you do
GLP-1 y
HIFU,
también
you guys know
utilizas el HIFU,
if you do
ubican el
HIFU at the
HIFU,
same time,
si lo utilizan al mismo tiempo, puede combatir sí el riesgo de tener, digamos, esta cara de Ozempic. Así que bueno, si ustedes están poniendo a sus clientes o el GLP-1 y utilizan el HIFU al mismo tiempo, no puedo recordar la frecuencia que se maneja en el estudio, pero bueno, básicamente, justo como habíamos dicho, o cualquiera que sea el protocolo, de esta manera pueden mitigar el riesgo de tener este aspecto, este rostro de Ozempic, ¿cierto? Incluso también se puede hacer con las células madre y los exosomas porque estamos estimulando el colágeno. Entonces puedes, en este caso, observar los efectos secundarios del GLP-1. Entonces, pues bueno, con base en la investigación que se ha publicado, sí puede ayudar con ello también. No sé si es lo que la respuesta que estaban buscando, pero bueno, esto sería mi comentario. Bien, entonces podríamos, ¿quieren tomar un receso?
Sesión 2. Medición clínica y optimización de resultados.
longevity. So who here wants to live forever? There's a few. There's a few. Who here wants to live to 100 with a high quality of life? Yes, most everyone. So I fall into the first category, which is I'd like to live to maybe 200. So and a healthy long life. There's just so much to learn. There's so much to do. So obviously that I've been obsessed with longevity since I can remember, and it obviously started out with fitness and bodybuilding and working out and all that stuff, and now obviously things have evolved and there's more than just supplements. And obviously just to as a disclaimer, the foundation is foundation, meaning nutrition, sleep, exercise, stress, the air we breathe, the light, circadian rhythm, all that stuff is the most important when it comes to living a long, healthy life. And that's never going to change. No matter what people say, that is still the foundation of health. And so you have to have those checkboxes in place, ideally, when you're going to come do these treatments too, because then they're going to be more efficacious. And we'll go into why that is, but that's part of the priming approach. So has everyone here have experience with doing stem cell infusions? Yeah, most people, yeah. So like sometimes I'm sure for longevity or for anti-aging, you're doing these stem cell infusions, and sometimes there's amazing results, and then other times people are just like, oh, I didn't notice anything, and they don't feel a difference at all. So that's always bothers me, because it's like, why are some people getting these amazing results and other people aren't noticing anything? And of course, the Muse cells help with that, potentially increasing the efficacy. But even with the Muse cells, I have had patients, they do the IV and they don't notice anything for longevity. They don't notice any subjective difference, which is why it's important to two things. One is to have some sort of measurement tool, so you have some sort of objective data to show them that the cells are doing something inside of your body, even if though you may not notice it in terms of vitality or recovery or whatever they were looking for. And the other aspect of that is improving the likelihood of success by priming their body first. So this is what I call, stabilize the cellular terrain. So we talked, the mitochondria, cell membrane, the gut barrier, inflammatory load. These are going to be the foundational things that we want to focus on. So how do we do each of those? We'll kind of dive into that a little bit. But, cell membranes are one topic that I think people don't get enough education on. And cell membrane is basically the security guard for your cells to dictate what gets in and what gets out. But cell membranes are made up of fat, right? They're made up of this phospholipid bilayer. And what happens is the cell membranes can become leaky. And so things that get out that shouldn't can get out, and things that should get in that shouldn't get in can get in. And so we want to stabilize and make those cell membranes as healthy as possible. And there are some tests out there that you can use. Again, I don't know if they're available in Mexico, but they have these. They call them red blood cell. It's a lipid biopsy, basically, which is looking at the cell membrane health. And then there's a test in the U.S. now, excuse me, called MeScreen, which is a mitochondrial test, but it looks at cell membrane health. And basically, what that means is then they can give you recommendations, based off that, to say that you need to take. It's not always as simple as this, but maybe taking more omega-3s. The ratios of your fatty acid, composition is off, so you need to take more omega-6 or omega-3, whatever it may be. But then there also are phosphatidylcholine, PC, which is an important kind of substrate to help with cell membrane integrity, and phosphatidylserine. And there's something called lipid replacement therapy. And there's a company called neurotrophic factors. But anyway, so lipid replacement therapy that can be used for people who have more, dysfunctional cell membranes, and sometimes that you need to get those cell membranes as healthy as possible before you're putting stem cells into the body. Because if the cell membranes are dysfunctional, at least, in my experience, what I've seen is that the stem cells just don't have the same ability to do their job. And I think part of that has to do, with how important that those membranes play a role in terms of just cell function. And same thing with, these other things. That's why I kind of listed those, the mitochondria we talked a little bit about before. And, gut barrier, there's simple things you can do. One of the things that I find that works really well, that's very simple for a lot of people, is there's actually for people, have you guys heard of the like KPV? It's a peptide. Yeah, so, but there's oral form. There's a company in Australia, and again, I know it's annoying because you have to source these from different parts, but that's the problem. You can't just get everything in one place. But there's a company from Australia called Level Up, and they make an oral peptide with BPC and KPV, which is really good for restoring the gut lining and the gut health. That can be used as a way to kind of stabilize the person before you're even doing peptides, for example, because even peptides, systemic peptides, injections are signals, right? And so sometimes you need to be able to get their, if they have severe gut dysfunction, then you may want to use that. If that could be your first step. Yeah, question?
Here regarding KPV for the gut barrier and, for example, FMT, have you seen any difference for restoring gut barrier?
Yeah, so FMT, we do have a manufacturer we work with that can do that. That's fecal microbial transplant. And so there is a group in China actually that's been studying this over, like they've done thousands of patients and they've done clinical trials for depression and all sorts of stuff. But so basically what they do is you give your stool sample, they match you a donor, and then the donors basically poop, but they're basically finding you the right match for you, and they make you customized pills. And so they have those now, like FMT pills or poop pills, as but they like to be, this is off-putting. So don't call that to your patients because they won't like that. But basically, I just call them like personalized probiotics. They're made for you, custom made, and they actually transplant new microbes into your gut. And that can be a very useful tool in severe, like severe cases or where they have autoimmune conditions. I wouldn't use that for like longevity, but for like people who have autoimmune conditions or neurodegenerative conditions sometimes as well, more chronic diseases. And then obviously there's testing you can do. There's a 16S RNA test you can do, and that can give you like an overview of the different bacteria in the body, in the microbiome, and then you can use that to determine if they're a good candidate for FMT. But I would say FMT, generally speaking, you won't need for most people. Definitely not for longevity. Yeah.
Thank you.
So yeah, we'll go a little bit more into that, but the inflammatory load too, like we talked about using the senolytic and using potentially SS31 for the mitochondria. Usually we recommend taking SS31 for 1 month before is the ideal, for like 4 weeks, 1 milligram a day to prepare the mitochondria. Not everyone has that. Some people come last minute, obviously, and they're like, I want stem cells. And it's up to you if you want to do it or if you want to at least put them on like SS31 for at least a few days or some sort of protocol before they come and do the stem cells. I just think, in my experience, that people see better results when you prepare their body for the stem cells. Did you have a question?
What do you think about the use of PEMF for the evening out like cell membrane action potential?
Yeah, PEMF, infrared light therapy, hyperbaric oxygen, those can all be used before and after. They're all adjunctive therapies. You don't, with like hyperbaric, for example, you don't need to do like 90 sessions. I've talked to some experts in the field about this. They say only like 2 to 3 sessions before and 2 to 3 sessions after stem cells is probably enough to increase the viability and increase their efficacy. So all these little tools can be used. Do I use them all the time? No, because we don't have everything at our clinic. I mean, if you have the luxury and you have everything at your clinic, great. You can definitely put it all together so that they're able to do all these things before and after the stem cells. So then, of course, once you've prepared the body, you've primed it, then you want to repair. The repair is obviously the stem cells. So let's talk a little bit about stem cells, because obviously that's my main area of expertise and kind of my passion, I guess you could say. So there's kind of, let's say, a ladder of stem cell treatments. So at the base of it is, I would say, stromal-vascular fraction, or BMAC, bone marrow aspirate. And that's where you just take the fat or you take the bone marrow and you spin it, you isolate, the healing component of it, and you basically inject it back into the knee or to a shoulder or into the face or hair, whatever the case may be. And that's not a bad option, but the problem with it is just, one is the host. If the person is relatively old, especially after age 40, actually, which isn't even that old, but after age 40, your stem cell, there's research to show that your own stem cells become, their cellular signature changes. So meaning they go from being these very potent anti-inflammatory regenerative cells to being more pro-inflammatory. And then after age 60 is when they can actually become even pro-cancerous. So, if you're taking someone else's stem cells after age 60 and you're culture expanding them, especially because the culture expansion puts more DNA damage on it, and you're putting them back in the person's body, you actually may be doing some harm. So that's why I'm not a huge fan of autologous cell therapy for longevity and for elderly people especially. I mean, if you're 20, you're young, you're healthy, it's probably fine and safe. So that's where you have to be a bit careful. And, in Japan, and where I've done a lot of, spent a lot of time there, they have cell therapy approved, but only autologous. And they've actually had a few deaths. They had one this year and one last year from autologous MSCs. And these were in older people. And I think it's because the cells are prothrombotic, so meaning they cause a clot, and then an unfortunate thing happens, right? So I think it's almost a misconception a little bit that people think that, oh, you're using cells from your own body, it must be safer. It's not true, and that's a perfect example. And then also we'll talk about the allogeneic, but the point is SVS and BMAC are kind of let's say generation one option, and I think they still play a role in certain like, for example, if I have a patient with a large rotator cuff tear, I will use the stromal-vascular fraction as a scaffold. And for the sports medicine or orthopedic doctors here, the size cutoff to which you can repair a tendon, in my experience, the experience of working with other sports doctors who've been doing this for like 20 years, it's about 2.5 centimeters. So meaning if the tear is 2.5 centimeters or less, it can still be fixed using a fat graft and stem cells in combination, or fat graft with PRP even. And basically, what the fat is doing is acting as a scaffold, right? It's just acting as a cushion to keep the cells or the PRP into where you want it to stay. And you can use that for full thickness tears, or tears that are even retracted. As long as the tendon isn't retracted more than that, you can typically repair it and avoid surgery. So that's one of the I say use cases of how we use stromal vascular fraction. I don't use it too much outside of that anymore. And then of course, after, let's say the autologous SVF and BMAC is, you can have MSCs, right? Culture expanded MSCs, which you can get from bone or fat or umbilical cord. And I think the MSCs are not bad, right? I don't want this to be like a Muse cells only, like trying to sell you on Muse cells or whatever. Like, MSCs are still decent. It's just they're not consistent. And the problem is, the reason they're not consistent is because there's different stem cell populations. So it's heterogeneous. So when you take umbilical cord or when you take adipose tissue, you have we think maybe up to like 10 different cell populations in there. So some of those MSC populations are better than others. Some might even be harmful. So it makes more sense to standardize the cell population, right? So then you have a homogeneous and one type of population. And that's why immune cells are so exciting, because now you have this one type of cell population, and you can obviously see the certificate of analysis, and you can see that, oh, we got like 70, 90%, and we have this marker, and we know that this is what we're putting into the body, as opposed to having this heterogeneous varied population. That just leads to more consistent results. And also, I think the problem with the MSCs too is when you're doing them for longevity, most of them are going to get trapped in the lungs, right? 99% is what the animal studies suggest. And the other issue is a lot of them don't survive. Only, we think up to 90% die in the body. So, and that doesn't mean they can't have an effect. I'm sure we've all had success with MSCs here. I have too. So there's obviously more to the story than just the cells themselves. It's the signals, right? It's the signals and how they interact with your immune system. So for example, a lot of the cells get trapped in the lungs, but there's something called bronchial alveolar lymphoid tissue, BALT for short. You have your MALT which is in the gut, and you have a BALT in the lung, which is basically this lymphoid patch where these cells interact, and then they're interacting with your immune system through that. So it's a cellular reprogramming effect. So that's why we think these MSCs can still have a benefit systemically, even though they're getting trapped in the lungs, majority-wise. So I'm not, so, because, some people are saying MSCs are useless and they don't work at all. I don't think that's true. I just think, you just have to be transparent, obviously, about what they can do and what they can't do. And then for the application of the, Muse cells, we'll go into dosing and everything, but obviously the Muse cells have a homing mechanism, which is what we think the MSCs are having. Part of the reason they're having benefit is 1 to 2% of the MSCs are Muse cells, right? So they're naturally occurring. So they're already existing in that MSC population. They're just a small percentage. So instead of just having 2%, we can now take it and we can have a batch that has like 90% or 95%. There is batch variability, but I think, and depending on who you talk to, some people say you should have a minimum 70%. I've heard, other scientists say 40% is okay. But, the point is, not just this is talking about the SSEA3 marker, which is a marker for the Muse cells. But then there's also pluripotent markers like OCT3 and OCT4. And those are also important to ensure that the cell that you're using is a pluripotent stem cell, and as opposed to being a multipotent stem cell, right? MSCs are multipotent, so meaning they can differentiate into certain types of tissue like cartilage, bone, muscle, fat, but they can't differentiate into everything like pluripotent. So that's why we want to use pluripotent stem cells. But historically, the problem with pluripotent stem cells was a risk of cancer, right? Embryonic and fetal stem cells have this tumorigenicity associated with them, meaning uncontrolled tumor growth. And then there's something called iPSCs, which are induced pluripotent stem cells, which were discovered in Japan in 2006. And they're basically using cellular reprogramming where you overexpress these transcription factors, which basically make the cell young again. So you can take an old cell and make it young into a stem cell, into a pluripotent stem cell. So obviously that's an exciting technology, but the issue is these pluripotent stem cells, or iPSCs, they have the risk of uncontrolled growth or tumor formation. And so that's why, but interestingly, the iPSCs have got approval in Japan. They just approved 2 iPSC products this year, one for Parkinson's and one for heart failure. And interestingly, because Japan is very biased, let's say, towards iPSCs, Professor Dazawa always likes to say, like hail Yamanaka, like hail Hitler for Japan. That's how much they love Professor Yamanaka, who's the guy who discovered iPSCs. And because obviously her work didn't get the same notoriety in terms of the Muse cells, even though Muse cells have the pluripotent-like properties of iPSCs. They're not as potent, but they're safer. They're non-tumorigenic. And in fact, there's preclinical evidence that she's published showing that when Muse cells come into contact with the cancer cell, they actually trigger apoptosis of the cancer cell. So meaning the Muse cells are potentially anti-cancerous. So they're safe to use. I'm not saying go use it for cancer, but at least if someone who's had cancer recently, at least you're not going to do them harm, and you're likely doing benefit for them. And the other reason why I'm confident you're doing benefit for them is because it helps to make their own immune system more resilient, and it de-ages their immune system. And your immune system, as an immunologist, I'm sure knows, your immune system is the best weapon in the world to fight cancer. So anything you could do to make your own immune system work better is going to ultimately help your risk of the cancer, but also many other chronic diseases, which is what these Muse cells do. We have data that we've published, for example, showing that the Muse cells, I have a case I'll talk about, but just to give it's a rheumatoid arthritis case where the patient went into remission, and we measured their immune system aging before and after, and you could see like a 10-year age reversal in their immune system. So basically, it's like we're making their immune system younger and making it function better, and it's resetting it, right? So basically, MSCs are not bad, but the other issue with MSCs is you have to use a relatively high dosing. So for IVs, often 3 to 5 milligram or 3 to 5 million per kilogram. What some people are using, and often you have to get up to 200 million or even more potentially. And with that, with more cells in the body, you're increasing the risk of having reactions too, right? And like what are called auto antibodies or immune-like reactions. And so they say about 10 to 15% of people will have those type of reactions to MSCs, whereas with Muse cells have something called HLA-G antigen. So it's a protein that's expressed that makes them immunoprivileged. And I talked about that yesterday. And so, but basically, MSCs are immunoevasive versus Muse cells are immunoprivileged. So they're not going to be triggered. They're not going to be cleared up by your immune system. They can integrate safely. And so that's what makes Muse cells, more have an ability to survive and do their job more effectively. So yeah, and then of course, there are other type of stem cells out there. I don't know, you guys maybe you've heard of, has anyone here heard of trophoblast stem cells? Human trophoblast stem cells, HTSCs. They're starting to be talked about because they're also pluripotent and they're easy to source from the trophoblast. But the risk, again, we don't know for sure, but I think there is potentially more risk with tumorigenicity. But if you talk to some of the people who are using HTSCs, they've been using them for, I know some people are using them for 10, 20 years, and they said they've never had any issues. So it is another pluripotent stem cell that might be safe. So just to keep your, I guess, eyes open to what else is going to be out there in the market. And the other one that I'd like to talk about too is, has anyone here heard of PAX cells? Pluripotent adipose-derived stem cells. So yeah, so they're actually, the paper written on that cell was in 2014, and they actually named them AT-Muse. So they named them adipose-derived Muse cells because basically they're Muse cells that derive from the fat, but they were just derived from a different process than the way Dazawa derived her Muse cells. So it's just a different process. And then I don't know what happened between the scientists or whatever, but for whatever reason, they changed the name to PAX instead of AT-Muse. But, functionally speaking, they're very similar. They still have a high SSEA3 marker. They still have, and then they have these pluripotent markers as well. So we don't really know. I don't know if anyone really knows the answer, if they are truly a different cell type, or are they just a subtype of a Muse cell? I mean, I don't know if anyone knows the answer to that at this point, but for all intensive purposes, for clinically speaking, you can use them as well. And Regen Global, they make both. They make the PAC cells or AT-Muse, and they also make the Dazawa Muse cells. So you have an option to choose from whichever, both. I think, just again, I'm trying to be unbiased and, just present my experience. I've used both, and I haven't seen I haven't seen a meaningful difference between the two. They both work very similar, and efficacy wise. So if there's someone, a lot of it then it comes down to cost, So that's the way I look at it. If you can, obviously for me, it's always about offering the patient what's going to be the most effective therapy, but also potentially cost, effective too. If you can get something that's cheaper and has the same effect, then why not, right? And that's where secretome comes in. That's a good segue into that. So we want to reinforce the signaling after they've done the stem cells. And in an ideal world, you could potentially do the secretome or secretome right after, like the day after the stem cells. And, Regen Global, I know, is working on the Muse secretome product and the PAC secretome product as well. They already have MSC secretome. So this will be available soon in Mexico. And the logic behind that is you've now put the stem cells in the body. What signals do you need to support them to differentiate and do their job? And that's what the secretome basically has. The secretome has all those signals, right? So that's the rationale behind it. And also, if I'm being completely honest, I could see secretome, like once the Muse secretome product is out or the PAC secretome product comes out, I mean, I could see it potentially replacing, Muse cells as a cell-free option. I think you could achieve very similar results. You just may need more frequent dosing potentially. And then again, you're reducing your risk of having to introduce any cells in the body. Not for everything, but for certain things. Like for longevity, if you have a patient who's local and they can come every month or two for secretome, that's probably going to have the same effect as like the Muse cell. And and it's probably going to be cheaper, a lot cheaper. So I think that's something to obviously, keep in mind. And then, yeah, the biomarker, we'll talk about the two things that I like to use, which are epigenetic clock and then proteomics, and how do we apply those to ensure personalize the treatments. So yeah, so we talked kind of about this, but basically the cellular terrain, we talked about the lipids. I guess I didn't mention micronutrients. Micronutrients, obviously, again, like if you're deficient in vitamin D and iron and you're throwing stem cells in someone's body, like it's not going to be optimal, right? So, you really want to make sure those baseline labs and those things are looked at. For me, most of the patients who come to us, they've already seen, they've already mastered the basics, right? They've already done all this stuff. They've done a lot of the groundwork. They eat well, they exercise, and now they're looking for, the top of the pyramid in terms of what else is available for longevity. Yeah, and then I guess the other thing that let's see. Yeah, we'll talk about this. So the other thing I guess for the cellular terrain too, does anyone here use plasmapheresis? Okay, so there's different types of apheresis, which is like, blood cleaning. And the problem is there's something called TPE, therapeutic plasma exchange, which has become kind of popular in the US. You might have seen people with a big bag of plasma and they're taking it out. That's actually not good for you because it's removing your circulating antibodies. It's removing, blood glucose, and it's actually maybe having some detrimental effects on your immune system. And people may see some improvement in blood work temporarily, but based off the research, there isn't any meaningful, long-lasting effects from it. And then it's potentially doing some harm because again, it's like you're throwing everything out, and then you're just diluting it with saline and albumin. So you don't want to remove the entire plasma. You want to be selective about it. So there's selective apheresis devices out there now. So there's a machine called Opti, and then you can get but I don't think it's available in Mexico yet. But there's basically two companies that make it. There's one called In-Use Pheresis, which is available in Europe and but different parts of the world. And then there's one called Clarify, which is in the UK and in Dubai at the moment. But I know these companies are working on bringing their technology to North America. So I feel like it will become available in Mexico and North America pretty soon. But just so you understand, don't let your patient fall for TPE, and I'm not a big fan of it. I think the In-Use Pheresis and the Clarify are going to be the ones that if they do want to do something like that, then that's the one. And the reason you'd want to do it, and again, it's not something you have to do all the time, but for a lot of people, microplastics and these forever chemicals, they're becoming a real problem, right? And so doing these interventions prior to the infusion, you're again making the environment more primed. You're removing some of that oxidative stress, some of that very high inflammatory load, so the cells aren't as distracted and they can focus in and do their job. So in Dubai, for example, our clinic in Dubai, we have in-use pheresis that we work, and so we can do in-use pheresis, and then they can do the Muse cells the next day. And I would say that it does tend to lead to, I do find that the results tend to be better in terms of more subjective improvements, at least. Like more people tend to notice, brain fog go away and more sharpness and vitality when you combine the two. But from the objective data, where we've been measuring, because we try to measure, we recommend everyone do the aging test with us before and after the stem cells. Not everyone does it. A lot of people just don't, but we try to get everyone to do it. And we haven't seen a big difference. I would say it's not like doing the in-use pheresis makes you young. You know what I mean? It doesn't add 5 years reversal to your biological age. I think the stem cells are the main thing that are going to do that, regardless if you do the in-use pheresis or not. But I think they're just maybe for some people, it might be a tool for them to prime their body to do that. Yeah. So we talked a little bit about this stuff, but what you want to kind of look at, before you're going to be able to put these stem cells in the body. So the gut barrier is, if they have some sort of autoimmune condition or chronic disease, you can almost 100% assume they have leaky gut, right? Leaky gut or intestinal permeability in the literature, as it's called, is 100% associated with autoimmune conditions. So everyone who has an autoimmune condition has leaky gut. And so again, you don't want to just throw stem cells into someone with autoimmune. You want to fix their gut first and do the foundational things. So like I said, that level up supplement I was talking about, that's usually what I would recommend you do first for like 2 to 4 weeks. And then you can introduce maybe like BPC 157, KPV systemically as a peptide. But first you want to do the oral one because the oral one's going to go target their GI tract specifically. And then and then we talked to mitochondrial substrates. There's obviously supplements and whatnot, and then membrane lipid health. I mentioned about the phosphatidylcholine and the lipid replacement therapy if it's a more severe case. And if you don't always have access to doing some of these more advanced tests, you can always be conservative, right? You can always tell your patient, hey, look, I think based off what I see from your blood work and what I'm seeing, I don't think we should do the stem cells yet. I think you should do this first and do this protocol for 2-3 months or whatever you think is best, and then we'll do the stem cells. And I think a lot of patients actually appreciate that too, because then they feel like you're not just trying to sell them on stem cells. And I've even had patients, I told them you need to work with one of my health coaches or one of my functional medicine practitioners for several months before you come see me. And no other doctor does that. Other doctors just are like, oh yeah, let's just do stem cells. Because they just want to make the money. And that's why a lot of them lose trust in this field too. So be one of the good guys and try to do things the right way. This was just to say a case, which I'll go over in a bit, but she basically had a depleted, her body wasn't ready for the stem cells, and then she had the stem cells done, and it was Muse cells, and she actually got worse afterwards, in terms of some of her symptoms, and it was because it had viral reactivation. So you do have to. So there are, and the other, I would say the two things, the viral chronic viruses and things like that. You need to be careful in terms of putting them. You really have to, prepare the body and have a proper protocol before putting the Muse cells. And then the other one is MCAS. You guys know what MCAS is? Mast cell activation syndrome. So you can. So that's something as well. You do not want to put Muse cells into someone with MCAS. It's just going to make them worse and flare them up. You need to first, there's a lot of other things that you can do for that condition. And then potentially you can even use a secretome. If you want to use a regenerative therapy, the secretome is safe to use and to help balance the immune system. But there's a whole other protocol for MCAS. But sometimes these patients get desperate and they look for stem cells as an option. So just you have to know to be careful with that. Yeah, so we already talked about the Muse cells and how they work. The sphingosine monophosphate S1P is the homing mechanism by which they go and find the area of damage, and the tissue differentiation, they're pluripotent, immunomodulation. So this is very important because it's not just about having immune system that is anti-inflammatory or pro-inflammatory. It's about having an immune system that's balanced and is able to react to things accordingly. So, because of course, what happens with a lot of patients with autoimmune conditions is they're put on immunosuppressants, and that's just suppressing the immune system. It's not bringing the immune system back into balance, right? So, but these cells can actually have that effect. And one of the mechanisms by which they do this is obviously cellular reprogramming of macrophages, T cells, but they can also potentially increase the function of T regulatory cells, which are kind of like the master regulators of ensuring your immune system is kept in check. And you can even measure, if you really want to get fancy, this is there's immunologists in here, right? You're the immunologist. So there's something called Treg to Th17 ratio. And it's something, is that a test you can do in Mexico? No? So in the US, there's a company called Lymphocyte Map, and you can actually get the different lymphocyte in the body, not all of them, but like a good detailed one. And there's something called Treg to Th17 ratio, which actually in preclinical in animal studies, they've shown is a predictor of MSC efficacy. So meaning, if the Treg to Th17 ratio, if it's imbalanced, there's too much inflammation, there's not enough Treg cells, then you're less likely to respond well to the stem cell treatments. So but even if you don't have that specific test, you can at least use that as a gauge to see if your patient immune system is very dysregulated. Then you may want to do some of the foundational work first, like the peptides, the supplements, before you introduce the stem cells. And then phagocytosis. So this is my favorite thing about Muse cells is how they work. They're like little Pac-Man, and they go and they eat damaged cells, and then they use the cellular machinery to turn into new cells. So that's their mechanism, which is what makes them really unique in terms of replacing tissue. Yeah, and then the secretome or secretome. So, obviously exosomes, I think a lot of people thought exosomes would be better than secretome, because I think people just thought, isolating a fraction of it and it's more fancy. So I think people thought exosomes was going to be better than secretome, because secretome is actually easier in a sense because you're just taking the whole soup, right? And whereas the exosomes, you have to isolate a fraction of that. But the good thing about the secretome is that it has more microRNAs, more proteins, and it has what's called the non-vesicular components as well, which is like outside of the cargo, other signals that can support angiogenesis and anti-inflammatory signals as well. So basically, I'll talk about a specific secretome product that we've been using in North America, but it's a placental secretome. But like I said earlier, Regen Global will have secretomes available very shortly. I think in the next month or two. But basically, it's the idea for there's two ways to use these secretome products or exosomes, which one is as an alternative to stem cells completely, or as a supportive one. I use it mainly as a supportive at this point, but that's because I don't have the luxury of the patients coming back often, right? Like my patients are coming once every year, twice a year maybe, or they're traveling. So if you're local and you're able to do repeat treatments, then you could potentially treat like a knee or a shoulder with arthritis using secretome. They just may need like 3 treatments, versus with the stem cells you could just do 1 with the Muse cells. So same, and that's the same thing we talked about with the cosmetics as well. And for longevity, there's some early data with the secretome showing you can get maybe like 4 to 5 years of biological age reversal. So it's still pretty decent, but you have to do it every couple months. I don't know the frequency. It seems like every 1 to 2 months. It's pretty often. With the Muse cells, we have seen cases up to 10 years of biological age reversal, which means that they were aging. Let's say they were 60 years old, and the biological age was 60. They did the Muse cells, and you repeat the test in like 3-4 months, and you see their age reversed by 10 years, go down to 50. So the biological age number is not the most accurate thing. I mean, it still gives you a decent metric. The one that's more accurate is actually the pace. It's called the Dundon pace score, or the rate at which you're aging. So for example, you could be aging faster than your chronological age. You could be like 1.1, for example. And then sometimes you can see with the Muse cells, you can see that go down by like 25, 30%. So you could bring it from like a 1 to like a 0.75 or 0.8. So that rate of aging is what's fairly accurate based off the research in terms of predicting mortality, meaning how long you're going to live and your risk of chronic disease. So it's pretty amazing that the cells with just 1 infusion can do that. Now, I wish I could tell you that lasts forever. It doesn't. I think the primary effect is still signaling, and there's some regeneration happening, but unfortunately, based off the data that we see, that it does wear off, anywhere from 6 months to a year, depending on the person. Maybe some people might be lucky and last longer, but what that means is the Muse cells are having a very potent effect on reprogramming your cells. They're doing what's called epigenetic reprogramming. So epigenetic reprogramming, epigenetics is basically what genes turn on and turn off. And as you get older, the genes that should turn off basically the genes that should turn off, turn on, and the genes that turn on, turn off. So basically your body is making more mistakes as you get older. And this epigenetic reprogramming helps the cells to do their job, basically restore their identity and restore their function back to the way it was. And there's a specific transcription factors called OSK, which I talked about a little bit yesterday, but those are the Yamanaka factors. But interestingly, the stem cells and exosomes, they work through the same mechanism, but they're doing it without gene editing, which is that they're helping your cells to overexpress these transcription factors, and then that's reprogramming the cells to function better. So basically that epigenetic drift, as it's called, is going to improve. I kind of think of it, the simple way to explain it is if you think of your DNA as an instruction manual, right, a book that these workers have to read to make proteins, that instruction manual gets water damage, it gets pages that are ripped as you get older and older. So there's more mistakes that are being made. So the people who have to make basically, the ribosomes and everything that has to make these proteins, the worker bees, so to speak, they can't read the instructions as well, and so they're making more mistakes. And what this Muse cells and exosomes is doing is they're basically helping to repair some of that instruction manual so they can read it better. So that's called epigenetic reprogramming. That's one of the main mechanisms by which this all works. And because of that, you can objectively measure a improvement in their biological age and their the rate of aging. Which is why I highly recommend, if you're doing longevity treatments, you get them to do some, because I think TrueAge is available here. You can use TrueAge, which is one of the companies out there, and then there's another one that I like called Generation Lab, which I think is also now they can ship. They can basically ship it to you, and then you just ship it back to the U.S. It's usually not a problem. From what I understand. So yeah, we talked kind of about this, model, meaning obviously assessing them first. If they're sleeping, if they're not sleeping at all and they're stressed, like they're and they want to do stem cells for longevity. Again, you may want to. It's probably better that they get that stuff in order first, and then yeah, you precondition. So getting the micronutrients and the mitochondria, getting the body kind of ready for everything. And then the review part is also important, I think, for follow-up. I try to get my patients to all repeat the testing within 6 months. So let's say they do the stem cells, they do the TrueAge test or the Generation Lab test, and then within 6 months, try to get them to do it again. Now, usually I say 3 to 4 months to repeat it, because there are cases where I've had where it seems like if you do it at 6 months, the results have already kind of worn off. So, but you want to at least show them that this has done something for their body, and then you can repeat it, another 6 months later, and you can see if the effects are still there or if it's starting to wear off. If it's starting to wear off, then they can repeat, do the infusion again. So then that way you have a more tailored approach. Of course, you can be generic and you can just say, just do it once or twice a year. I think that for a lot of people that still works, but for if they're investing all this money into it, it's nice to be able to show them some objective data that you're actually doing something to slow their aging, as opposed to just saying like, oh yeah, it's going to work. It's doing something, Yeah, so this is kind of just like some of the pearls I've learned, which is basically that doing like the whole protocol. I kind of, when I first got into this, obviously I didn't have this protocol. I would just do stem cells, and it was very annoying when it didn't work. So, I just kept trying to look and see how we can improve things. So this is something that I've just, over the years and trying to refine the process of how to make everything better. And then, yeah, I mean, in terms of the biomarkers, I've never, outside of the MCAS, just again, this is for people to understand with the Muse cells, they are very safe, and it's very unlikely they'll have any sort of reaction. The only time I've ever seen a reaction was with a patient who, like I said, who had MCAS, and that caused, that made them worse. So other than that, I can't think of any other contraindications or reasons why you can't do the Muse cells on someone. Obviously, breastfeeding and pregnancy, but outside of those, and MCAS is very safe to use. So, because obviously, if people are coming to you for longevity, they're already healthy, right? So you don't want to make them worse, and you're not going to do that with the Muse cells. It's gonna and you're gonna have data, and you can have data to back that up as well. And again, when I say Muse cells, you can interchangeably use them with the PAC cells. They're both gonna have similar effects. So yeah, so basically, I think the big take-home message here is that we want to get their body ready for it, and looking, at the inflammation, the oxidative stress, the gut health, kind of doing all those foundational tools before you're gonna give them the stem cells. So prime the body, repair with the stem cells, and you can reinforce the signaling with the secretome. That's what leads to best results. And yeah, I think that's pretty much it for this part. Yeah. Is there any questions? Yes.
You were speaking about the lymphocyte map that Cyrex Lab offers. What do you think if it's very low, would you think of offering NK cells to boost the immune system, or could it?
Yeah, exactly. You can measure it. It can give you a count of the NK cells as well, and then you can measure that to see if it's low. Now, I don't know. I haven't personally seen when you do NK cells, like you can see a boost in the levels, but it doesn't always maintain. Some people need multiple infusions to really see. Like, I don't know, what dose are you using?
Well, I was just thinking that maybe one day we can use that map to prevent with people with a low immune system, to prevent
Yes,
that.
exactly. Oh yeah, for sure. And again, it's not about necessarily having a low immune system, but having an imbalanced one, right? So you can see if there's imbalanced immune system, immune dysregulation happening at an earlier stage, and then you can intervene, right? You can use peptides, you can use all these things, and to help their body to become stronger, and you're going to reduce the risk of having problems down the road. And there's a lot of good research on this. They did a 17-year-long study at Stanford and they use this epigenetic clock, and then they also measured their immune system aging, and they found that the immune system aging was the most accurate predictor of, like, how long they're going to live and everything. So basically means if we keep your immune system healthier longer, you're probably going to reduce your risk of disease and live a longer, healthier life.
But would interjecting with NK cells at this point, as for prevention, could it have any possible side effects?
Well, yeah, exactly. I mean, NK cells are also help to get rid of senescent cells, right? They're like sponges for that too. They help to remove them. So I think in older people, it might be some utility in using the NK cells because they have more senescent cells in their body, obviously. But I just don't think there's enough. I don't have enough. I personally haven't used them outside of really, cancer patients, but I have used them in a few patients for longevity, where they do the NK cells first. These were in older people, and they do the NK cells first, and then you wait 3 days, and then you do the Muse cells. But I don't know if it really makes a big difference. You know what I mean?
Thank you.
Yeah.
My congratulations. It's a very, very good experience with you.
Oh, thank you.
My question is, you talk about the measurement of the biomarkers. What is in your opinion, the best biomarkers to obviously inform basically for a patient that start with the treatment? What is the biomarkers that you recommended to stay in close surveillance in the treatment?
Yeah, I mean, in an ideal world, the best biomarker, and I was saying this yesterday, would be the proteomics, because proteomics is a real-time measurement of all the proteins in the body, and it can correlate that to different pathways as well. So there's a company called Sedona Health. I was just talking about them on my social media because we're doing a pilot project with them, but they will be available in Mexico soon. I know they're expanding. But basically, it's just a blood draw you do at home. You can do it at home, and it just attaches, and it's just a one blood draw, and it can give you over 1,000 proteins, and that can link to so many different pathways, right? And then that can give you really insight and details on what's dysfunctional and what improves after the longevity treatment that you're doing, whether that's peptides, whether that's cold plunges or sauna, whatever you want to measure it, the proteomics can give you the most accurate real-time measurement of how that longevity intervention is working. Now, proteomics isn't available yet in Mexico, so the other, you can still do for general panel, the inflammatory markers like HSCRP, IL-6, like a cytokine marker, I think is good to have in there. And then obviously there's just a general kind of blood work that you could do, but I would throw in like homocysteine and, kind of like the different, from a blood panel perspective, I don't know, because you guys don't have Cyrex labs here, right? Zelo, you don't have Cyrex, yeah, because there's all these advanced labs they have in the US, but they're not available anywhere else, so it's kind of annoying. But basically, for at least a very basic, you do like fasting insulin and A1C. You look at their metabolic profile, their liver, kidney, their blood count, and if you can get a more detailed lymphocyte count, that would be good too. And then at the very least, a few inflammatory markers, and then you can monitor those.
Sí. Aquí.
Yeah.
Nosotros aquí en México utilizamos biomarcadores como son la homocisteína, la hemoglobina glucosilada y la depuración estimada de creatinina, considerando definitivamente los exámenes generales de una biometría hemática, un perfil bioquímico 30, por ejemplo, y un examen general de orina. En la falta de disponibilidad de los laboratorios norteamericanos, nosotros estamos comenzando a hacer un protocolo de biomarcadores adecuados a México. Entonces, cuando nosotros valoramos el estrés oxidativo, homocisteína nos puede ayudar bastante en la cuestión de verificar cómo se encuentra la oxidación en México, ¿no? Del paciente. Entonces, estimar depuración estimada de creatinina, valoraríamos también si el paciente está en un grado de insuficiencia renal crónica avanzada con valores menores de 60. Hemos visto pacientes que se están tratando con células madre, infortunadamente, con valores menores a 60 de depuración estimada y están presentando, esos son los que han presentado algún tipo de problema. ¿Qué nos podría comentar al respecto?
I'll need some help with translation there.
Yeah. There's some biomarkers that you use that we don't have here in Mexico, but here in Mexico we use like the in general the general blood panel, like blood chemistry, like the biometrics, all that stuff. But there are some patients with low kidney function, like high creatinine levels using mesenchymal stem cells or stem cells. How do you think we can measure the oxidative stress here in Mexico when we have that kind of patients and we don't have the same tools that you have? Perdón, lo resumí un montón, pero no me la aprendí toda.
Why does he want to measure oxidative stress for that specifically? With chronic kidney disease, you can measure something called C-statin C, which is another way to gauge the disease progression. And then if you do infusions of Muse cells or MSCs or whatever, then you can monitor that to see if there's improvement. And in my experience, you can see improvement with the IVs, but they often do need like 3 infusions to see a decent result for the chronic kidney disease. But why? I don't know if I understand why would he want to measure oxidative stress, specifically for that condition? Is there a reason, or why do kidney patients?
Why patients with kidney failure, they have side effects with the stem cells, because what he's seen, and I have seen it too, when we treat patients with kidney failure, they don't improve as we see very good result with another kind of disease, So that's, yeah.
So, I mean, I can't say the results. The only time, I mean, I've seen decent results in cases where they have, like, for example, like anabolic steroid users, and they use steroids and they damage their kidneys. Like, I have seen positive results in that. Of course, if they're on dialysis or they're end stage, then yeah, it doesn't really help. But I haven't seen it personally. I haven't seen it have any adverse effects. Either it works or it doesn't. You know what I mean? And I think you have to be realistic. If their EGFR is like 20, you can maybe bring it up like 5 points, maybe 10 points if you're lucky. But they usually need like 3 infusions at least to see a good result.
Okay, another question. You said that be careful with the patients who had very bad immune disease, One of the main benefits with the stem cells is that they modulate that immune system. I have treated many patients with immune disease like lupus, sclerodermia, and I have seen very good results. Obviously, we have to treat the gut, we have to treat the oxidation, the inflammation, give the patient, measure the cortisol, and give the supplementation that the patient needs, not only, give the stem cells. That's why I have the results that I have, I believe that it's not just to apply the stem cells.
Yeah, exactly.
You have to give to treat the root of the cause of the main cause of the disease. So, but I wonder why.
Yeah, sorry, I maybe I misspoke, but what I meant was you don't it can help with immune dysregulation, but you don't want to throw it into a body where like, for example, like MCAS. Like, that was a very specific.
Especially with MCAS.
Yes, specifically with MCAS. And then the point I was trying to make is that if the immune system is very dysregulated, you may not get the result that you want without doing the other stuff. So that's why, but clearly you're doing that. So that's what, do the peptides and the supplements and all that stuff first, get their immune system in a better place, then you do the stem cells and you'll get better results.
The first one, they are questions from online doctors. Dr. Maria Elena, which cellular lineage do the Muse exosomes came from? Which cellular lineage?
Well, they come from MSCs, basically, and then they're just using cell sorting technology to isolate the Muse cells, and then they can create exosomes or secretome from that.
All right. And second one, it's also from Dr. Maria Elena. How good of an option is it to apply placenta instead of using secretome when it isn't available yet?
Well, there's actually a placenta-derived secretome product that is available in the US, and I'm sure there's manufacturers in Mexico who make it too. So I personally seen very good results with the placental-derived secretome as well for different diseases and for basically all the same applications that you can use the Muse cells for, but except it's just a cell-free option. So I guess, so to answer your question, you can still use placental secretome. It's just that they'll need more frequent dosing is what it pretty much comes down to. And you can still get very similar results as the Muse cells.
Muy bien, doctores. Pues antes de irnos a nuestro siguiente descanso, por parte de Regene Global, les queremos presentar lo que viene a continuación dentro de nuestro corporativo y nuestro laboratorio. Démosle un fuerte aplauso, por favor, al doctor Adeel, y después de esto que les vamos a mostrar, nos vamos a un descansito.
No. Thank you.
Sesión 3. Regeneración sistémica en las enfermedades crónicas.
So now we're going to focus a little bit more on, so we talked about aesthetics, longevity, and now we're going to talk a little bit more about chronic diseases. I'm sure a lot of you have experience with autoimmune conditions, long COVID, fibromyalgia, chronic pain, of course. So these are different type of things that we see, and I'm sure that you guys see as well. And so I'll share some of the, our protocols, but also some of the, science and logic behind why we do what we do. And it can be very life-changing for people with chronic diseases because you can get people into remission. But again, I think the preparatory work has to be done as well, as we talked about. This was just kind of, just generally like, in terms of tracking, and obviously, like if you're doing cosmetics, do before and after pictures with the same lighting. I'm sure everyone knows that. And then, there's questionnaires that you can do. And then, the optional selective, we talked a little bit about that, like the epigenetic panel, the 16S RNA for microbiome. And, but you don't need to do 100, and the other problem is doing too much testing, which a lot of functional medicine doctors do. They do too much too. So you got to find the right balance where it's like you're doing the minimum to be able to gauge the efficacy of the treatment, but and make sure you have diagnostic clarity, but you're not ordering tests just for the sake of ordering more tests. So this is just more on photo. This stuff is pretty basic, so it's just kind of like, obviously documentation with the lot numbers, everything, the same protocol. I'm sure everyone here does that type of stuff. So we talked a little bit about the epigenetic clocks, and I guess has anyone here used TrueAge? One person. Okay, well, one person's good. So it's available in Mexico, yeah. So you could use TrueAge or Generation Lab. Those are two I'd recommend. I personally like Generation Lab a little bit more because they use something called biological noise, and it's just based off the data, it seems like a more accurate way to measure aging than the traditional epigenetic clocks. And the important thing is not to get fixated on just the biological age number. Have you guys? There's so many biological age tests, right? There's like people use Whoop. There's one called GlycanAge. There's a lot of different companies coming out with these aging clocks, but the accuracy is not always there. And the number, like I said, the number itself is not as important as the rate of aging, the speed of aging. So that's what you want to look at. It's called the Dundon-Pace score. You'll see it on the report, and that to me is the more valuable metric. And then, before and after stem cells, you can see these numbers change, of course. And with the proteomics that I was talking about earlier too, the proteomics has an aging clock as well. So with the proteins, you're able to gauge the aging of different organ systems and be able to see before and after the treatments how those things have changed. So I do think in an ideal world, you would combine epigenetic clock with proteomics. And if you have both of those together, that gives you the fullest picture of how someone's aging. And you can give them objectively that the treatment that you did had a real effect on them. And the reason also is because they're two different tools. Epigenetic clock is based off methylation, right? Which is, again, just basically the epigenetics and how many mistakes your genes are making and whatnot, versus proteomics. Proteins are the end product of gene expression. So there's a lot of intermediary steps that happen, and how those proteins function. Proteins are the workers in your body, right? They're the ones that are responsible for everything in your body in terms of getting things done. And how those proteins are made and folded, and what's called post-translation of after they're actually made, post-translational modifications, what happens to them is what actually gives you a really good picture of what's going on in the body. So I know I keep talking about it, but I think being aware that proteomics is the next, let's say, revolution in diagnostics is something that's exciting and something you guys should all be aware of because it's going to become much more common over the next few years. So this was an example of a patient with rheumatoid arthritis. So their chronological age was 45, almost 46 years old. And then after the treatment, they went down to 39-year-old. But what we can say is we rejuvenated their immune system because we were able to see that their immune system specifically had significant reversal in the aging process. And then it's about how you phrase it is what I wanted to get across too. So you want to say that the age decreased relative to chronic age on epigenetic treatment. It's a case level observation, right? You can't assume causality necessarily, but yeah. So you don't want to necessarily say that you reversed it, but you decreased it. So the wording is important, just so people, you don't want to become you don't want to make it seem like a sales pitch or marketing and hype. I think it's important to be honest with them what this is showing and what this means. So in terms of this case and specifically, I'll give you the detail. So the protocol that we did for rheumatoid arthritis and autoimmune, ideally, we'd like to do, the apheresis for them if we can. Again, we don't have that luxury in Mexico, but the reason is autoimmune. One of the leading theories as to why we get autoimmune conditions is what's called molecular mimicry. So these are basically chronic infections, chronic toxins, even parasites, things that are in the body that trigger your immune system to kind of go haywire. So if we can lower the toxic burden in your body, it can allow us to reset your immune system more effectively. And that's why we like these blood cleaning technologies like immunopheresis and whatnot. Now, if you don't have that option, but there's still, other things that you can do. So for example, often what we'll do with our autoimmune patients is before doing the stem cells, we may do something like thymus bioregulator. Does anyone here have experience with bioregulators? No? Yes? Yeah, so bioregulators are basically like peptides, but they work on organ systems, right? So for example, there's like kidney bioregulator, liver, heart, just different types of bioregulators, and they can help to increase the functioning of that organ. That's the idea behind them. And we know with the thymus gland is very important for your immune system because that's where T cells are made. And what happens as you get older is they shrink. And we know with people with autoimmune conditions, the thymus gland isn't functioning as well. So the T cells that are supposed to be doing the job don't do it as effectively. And so essentially what we're trying to do is we're trying to upregulate and support that. So one of the things that we do for a lot of our autoimmune patients is we would recommend you doing the thymus bioregulator and something like thymosin alpha-1, and doing that for like 4 to 6 weeks prior to the stem cells. And essentially the idea there is you're getting their immune system in a more preparatory type of state before you're infusing the cells. Now, you can infuse the cells and sometimes you get miraculous results. Like this patient was just one treatment with 80 million Muse cells. Now, 80 million is a relatively high dose. He was about 100 kg. So he was a bit on the heavier side. And, and also because of his autoimmune condition, that's why we chose to do a higher dose. But typically, with these type of cases, a lot of times they may need 2 to 3 infusions to get into remission. But this case in particular, with 180 million infusion of Muse cells, is able to go into remission, got off all his meds, his prednisone, his biologics, and he's been fine ever since. He also did lose a lot of weight. So I think that helped a lot too. Obviously, your metabolic health improves and you have better control of your immune system. So, yeah. I mean, for this type of stuff, it's more documentation and just trying to be able to, again, being able to explain to the patient that these are obviously experimental treatments. And, the way I always explain it to people is that these treatments are very unlikely to make you worse. Typically, the worst case scenario is that you just don't get better, right? And so being able to understand and say that I always say the biggest risk to stem cells is the cost, because it's not, cheap depending on where you go. And that's really the risk that they're taking, is that they might spend all this money and they may not get a result. And so that's the thing I caution people on, and you have to be upfront and transparent about that, I think. So people, it builds trust too, of course, because, as opposed to you just saying, oh yeah, this is going to work, you're going to be great. And if it doesn't work, then they're going to be very upset. So it's better to be honest upfront and then tell them, in terms of adverse events, I personally have seen some adverse events between, the stem cells and some anesthesia where they got almost like an inflammatory type reaction. Has anyone else seen that or experienced that ever with remifentanil or fentanyl? Do you guys ever use that? So I don't know if it was just, but I have seen some people get almost like a systemic inflammatory response. So anyway, so if you're doing anesthesia, I personally avoid those drugs. I don't use remifentanil or fentanyl. We just usually use midazolam, because our procedures aren't that. Sometimes for spine procedures, they need a little bit of sedation. Usually midazolam is fine, and then a tiny bit of propofol if needed. And then we've never had any issues with that. But when we were using the fentanyl, we did have a few cases where they got this systemic inflammatory response. So I would be, if you are using anesthesia, I would just based off our experience, I would probably not use those drugs and just stick to the cleaner, let's say, the cleaner ones like propofol, midazolam, and yeah. Other than that, with the Muse cells, like I was saying earlier, because they're immunoprivileged, you're typically not going to get that immune response. With MSCs, sometimes you have to tell them you might get flu-like symptoms for 1 or 2 days. You might feel unwell. You might feel tired. But with the Muse cells, you don't really see that. And in fact, usually with the Muse cells, if they have a good response, sometimes they'll literally the next day, they'll be like, I feel great. I feel more energy and I feel better. Same way, again, Muse cells I'm using interchangeably here with the PACs or adipose-derived Muse cells because they're both very similar to me. And so those are both, to me, at least clinically, they function the same. And yeah, so, chronic disease is basically a systems biology approach, right? So everyone here has heard of functional medicine, but I don't actually like the word functional medicine. Systems biology is a more accurate term. That means that how does the whole body interconnect and lead to disease? So for example, if you have Alzheimer's, it's not just a brain problem. We know it's a gut problem as well. And why do we know that? Because there's so much evidence, both in animals and in humans, showing that they have certain bacteria that are missing or certain pathogenic bacteria. And what happens is those bacteria can actually lead to the brain barrier becoming leaky. So when the blood-brain barrier becomes leaky, then you get cells that go into the brain that shouldn't. So for example, you get immune cells and these immune cells are called microglia in the brain. They're called macrophages, in your blood. And those microglia trigger neuroinflammation. And that neuroinflammation is what drives these neurodegenerative conditions. One of the biggest drivers, not the only thing, but the point is a lot of that starts in the gut. So if you're only treating the brain, you're not really treating the whole picture. And that's why it's important to understand the systems biology approach for chronic diseases and how to look at it kind of from a first principles perspective of what's actually the root cause. So, in terms of, kind of the approach, you want to be able to figure out if there's, there's different type of subtypes, of these kind of different conditions. And then what drivers, in terms of substrate, we already talked about that. And then, the load thing, we talked a little bit about, earlier we're saying with autoimmune conditions, you just don't want to necessarily, if they're very immune dysregulated, it's better to work on that first using the supplements and using the peptides and, improving the gut health and all that stuff that we talked about before you necessarily throw stem cells onto there. And then subtractive before additive. So what that means is subtractive medicine is that whole concept. So subtractive medicine is basically removing microplastics and these toxins from your body, right? And so that's going to become more mainstream, I think, over the next few years. And I know that there's a clinic. Have you guys heard of HHO? Have you heard of it? You know everything. You're very knowledgeable. HHO is hyperperfusion and hyperthermia oxygenation, and it's this device in Vienna, but they're coming to Bahamas now, and I think they're going to come to Mexico soon too. But basically, it's this really unique approach in combining these different modalities to try to really purify and clean the blood. And when you heat the body first, what that does is the theory behind that is the hyperthermia helps to remove intracellular pathogens, from the inside the cell into the blood, and then you can clean the whole blood. And this is actually cleaning the blood versus just the plasma. Like in-use-pheresis and the other devices are just the plasma, which is a fraction of the blood, right? So versus the HHO is doing the entire blood. So there's potentially maybe more risk with it, but it's also very effective, for people with like long COVID, Lyme disease, those chronic infections that can be really tricky to treat. If you can do that first and then do the stem cells, you can get amazing results. And that's kind of the sequence of events in the ideal world that you would do. So in terms of what, if they're in I guess the big take home here is, if they're in the flare up, you don't necessarily want to put these stem cells in, right? And I think the acute, with like whether it's rheumatoid arthritis or if it's inflammatory bowel disease, you want them to be somewhat stable and have that immune balance picture before you're putting those stem cells into their body. Now, for example, we've had patients even with inflammatory bowel disease without doing FMT or anything like that have gone into remission with just the IVs, just needing like 2 IVs. So you can definitely, it's very achievable. It just has to be the right environment and the right picture when you're putting these into the patient. I guess, So, with the metabolic stuff, there's Regen Global, for example, I know they're working on a metabolic secretome. So there's going to be a secretome product specifically for metabolic that's going to be prime. So I think those type of regenerative therapies will be very interesting. To be honest, I don't really need to, the stem cells I haven't used so much for metabolic. Usually, if you do peptides, you can usually cure most metabolic diseases, right? With like diabetes and obesity, you can really improve that. So have you guys heard of retatrutide? It's kind of like the 3rd generation, Ozempic, have 3 different mechanisms of action. So, and it seems to work better, and you can combine that. You can stack it though, right? So what I'd recommend for these metabolic conditions is don't just put them on a GLP-1. You have the luxury of having flexibility, especially in Mexico where you're allowed to do peptides, right? So you put them on something to protect their muscle as well. So put them on like CJC, ipamorelin, which is a growth hormone peptide, right? And it can help to protect muscle loss because when you put them on a GLP-1, 2/3 of the weight they lose is fat, which is great, but then 1/3 of the weight they lose is muscle, which is not so good because then you're actually reducing that metabolic reserve and the resiliency in the body, especially if they're going through a yo-yo dieting, which happens to a lot of people, which is that they lose weight and then they gain it back. And then now they've gained the weight back with less muscle. So they're actually worse than they were before. So as their doctor, you have to be very cognizant of these GLP-1s and the risks with them too. Of course, protein intake, making sure they're getting 1 gram a pound per body weight, and resistance training are going to be, foundational. But in terms of what you can do, you can add those peptides. And then the other, a peptide that I would say for metabolic health that works really well, in the combination you can do. So this is one of the protocols from one of my health coaches who works with a lot of pro athletes and a lot of people with metabolic issues too, is you could do SS31 with 5 amino 1Q. You guys know that one? So that it's with that, because that can improve insulin sensitivity, and the SS31 can help with the, like I said, with the electron transport chain. So basically, you're repairing the mitochondria and you're making it more efficient, and then you can do that for 4 to 8 weeks, and then you can introduce something like MOTC. And MOTC increases the output of the actual mitochondria, but you don't want to increase the output of the mitochondria until you've made sure it's repaired and functioning optimally. So that's why the order is important. So, but that again, you can combine those if you really want like the ultimate. I call a lot of our people do this and they love it, and you can do the Reta, you can do the SS31, and you can do the CJC ipamorelin together, and then on a 12-week like let's say course, and then you can switch them to the MOTC after 4 weeks or after 8 weeks of the SS31. So that works. If they don't lose weight on that, then there's something wrong. There's probably a hormonal problem, or there's something else going on in their body that you need to dig deeper, because everyone will lose weight on that. Like I've never seen anyone not lose weight and improve their metabolic health. So I think for metabolic health, we have amazing solutions with peptides now, and you don't really need stem cells for that. In terms of type 1 diabetes, obviously, is a different conversation. If they're obviously, with the Muse cells, I haven't really seen, with the IV, it doesn't really do much for type 1, but I think the approach that will be there is maybe intra-arterial, where you inject the Muse cells directly into the pancreas. And that's something that's being researched. And I know doctors, some interventional radiologists who are looking to start doing that in Mexico. So I think that will be very interesting. And then you can combine that with FMT as well. One of my colleagues, Dr. Sabine Hazen in the US, she's had patients with type 1 diabetes go into remission with just FMT, which is really amazing to see, because obviously it's the gut and the gut immune access and everything. But I think the future of type 1 diabetes, at least, is probably combining FMT with some sort of cell therapy to regenerate some of the lost cells. So that I think that will be very promising. That's something we're looking to hopefully do once we get the interventional radiologist set up in Cabo. I have one of my friends who does that, but we want to start offering that procedure. So neuroinflammation, as we talked about, is one of the biggest drivers. But like for example, in Alzheimer's, they always talk about the plaque, right? They always talk about the plaque in the brain, and all these drugs are targeting the plaque. But the tau proteins are not they're just a downstream effect of mitochondrial dysfunction, of neuroinflammation, of everything else that we, with the gut, everything else that's going on in the body. And so it's kind of silly and almost comical that these drug companies think that they're going to solve Alzheimer's. I don't think they're that dumb. I personally think drug companies are evil. So they know that this is not going to solve the problem, but they can show like an incremental improvement, and they can get FDA approval, and then they can make a bunch of money. And then even if it's gone after a few years of whatever, they've made their billions of dollars and they're happy. Versus actually trying to solve the problem, you need to take a multimodal approach. You need to do all the stuff that we talked about. And for Alzheimer's, Parkinson's, ALS is a little bit different, but let's say for Parkinson's and Alzheimer's specifically, the approach that we take is like all that priming stuff that we talked about earlier is important. But then we can also do something called a intranasal administration of the Muse cells. And this has really come a long way, at least from before, I think. You don't have to use a normal needle. There's 2 devices on the market that you can use to administer the stem cells directly to the brain. And one is called Curve, Kurve. And it's been shown, it's an atomizer. So basically, it's almost like a nebulizer, but the way the device is designed and the mechanics behind it, they've shown in their research, they've done phase 2 clinical trials in the US, they've shown in their research that this device can administer up to 99% of the medication directly to the brain via the olfactory nerve. Versus if you're doing a nebulizer, 60-70% is going in the lungs, and then maybe 30% is going in the brain. And then when you do an IV, even with the Muse cells, we think only 1 to 2% are maybe going to the brain, and the rest are going systemically. So it's just a completely different order of magnitude of delivery you're going to get to the brain when you use the Curve device. And you can order, your patients can even get out. I mean, it's kind of expensive to get at home, but if they're, they can if they want, and they can always do it at home themselves with lyophilized exosomes and things like that. But even if they can't do it at home, you can get one for the clinic and you can offer it at the clinic. And typically what we recommend for Alzheimer's or Parkinson's is to do 3 sessions of like intranasal, 20 million Muse cells, and then do IV 20 to 40 million at the same time. And you do that like 3 months apart, and you do 3 sessions of that. That can lead to really, really good results. You're right in that there's always going to be pushback from other physicians and other specialists. So I think, one thing that we can all do to help to move this field forward is trying to publish case reports, even if it's just a few cases. There just isn't that much data published, right? And so that's what we try to, we've published a few case reports on the aging and some of the musculoskeletal cases we're working on publishing and things like that. And, that just helps at least to say like, hey, at least there's some published evidence, and if it's being reproduced by different practitioners around the world, then that's what it really shows them that this is, a potential therapy. Because, a lot of, academic or mainstream doctors, they won't believe anything, even if they see it, they won't believe it unless there's like published evidence, And so the other thing on that is obviously having actual clinical trials for this type of, conditions. And that's unfortunately does cost a lot of money, but there are, people working on that. I know there's a Muse cell clinical trial for autism going on right now in Europe, and a phase 1. And so, it'll progress, right? There'll be more controlled evidence. But we all know here, we've seen the results in real life. Like, we know these things can work. So for us, it's more just to validate our work. But I think the way I talk to other physicians about it is usually telling them that it's about the risk versus benefit too. A lot of these treatments, especially with these newer type of cells, they're very safe, and there isn't a big harm in trying it. And especially for a condition like autism, where there isn't that many other solutions, why not give it a try and see if it helps? And I think the other thing, just to answer your part of your question, you're saying what other therapies might be out there. Again, FMT, fecal microbial transplant, they're using that in China. I know because I was just in China for actually curing autism and treating it, just FMT on its own. And same with Dr. Hazen in the US has been doing that too. So you can use FMT with stem cells if you really want to get like the full, let's say, effect, or if you have a very challenging case. So I think those are, but that just reinforces the idea that the gut plays a big role in terms of, neuroinflammation and brain function, right? Is FMT available in Mexico? Not really, right? Yeah. So yeah, we'll see if we can fix that. Yeah. So I think I talked about that case a little bit. The one that had the reaction to the Muse cells without, because she didn't have her body primed. And then this one was the rheumatoid arthritis one that, had the 80 million Muse cells and was able to go into remission. And the fat graft and the Muse cell, that was he also had a shoulder issue and a knee issue. So we injected the Muse cells into his shoulder and knee as well. And, that got rid of his pain. But the reason we use a fat graft is because he had a focal full thickness tear. So if you have a full thickness tear and you just put the cells in there, they're just going to migrate. So you need something to cushion it and hold that together. So that's what the fat harvesting is for. Okay, well, yeah, I mean, I guess, for other type of chronic diseases that we see commonly, yeah. Sorry?
You mentioned the fat graft, but you also mentioned the hydrogels. Have you had any comparisons regarding when to use fat graft and when to use
yeah, it's a good question.
Hydrogels?
Hydrogels are okay if the tear is like if it's like I'd say like half a centimeter. For like say sometimes you can have what are called focal full thickness tears, like for example, in like the elbow tendon or something, those are common. And so it can work well for those smaller ones, but anything bigger than that, the hydrogel is not going to be big enough to cover it. Let's say like half a centimeter would probably be your cutoff for using a hydrogel with the cells. Yeah.
Thanks.
Yeah. So the other thing with the, with the chronic diseases that I wanted to talk a little bit about was with, does anyone here ever do a stellate ganglion block or heard of that? SGB? Yeah. So, because we do a procedure which we can show on the ultrasound after too, is where we inject the vagus nerve and we do a stellate ganglion block at the same time. And basically, because a lot of chronic diseases, they can have dysautonomia as part of that condition, and they can have an imbalanced nervous system. Obviously, with PTSD, anxiety, mental health stuff, that plays a role too. But it can also be playing a role in different chronic conditions. And and there's some conditions that are completely related to that. For example, POTS, postural orthostatic tachycardia syndrome. That's very much related to dysautonomia. And so if we want to rebalance or reset the nervous system, this is one of the tools to do it. And it's really can be a very useful tool in your toolbox. Again, you need to obviously learn to do the ultrasound part. But if you're an injector already, it's something you could add potentially to your kit. And what we do is we inject into the stellate ganglion, you inject what's called bupivacaine, which is a block, so that's a more traditional procedure. But we mix it with peptides as well. And then we also inject the vagus nerve, but we inject the vagus nerve with the Muse exosomes or Muse cells, depending on the case, and peptides. And the idea is the vagus nerve, for those that don't know, is one of the biggest nerves in your body. Comes from your brainstem, splits into two, and then comes back together. It's like a highway from your brain to your gut, right? And if the vagus nerve is dysfunctional, it can even be related to gastroparesis and things like that. So there's a lot of different kind of downstream effects that can happen as part of vagus nerve dysfunction. And one of the other conditions that we've helped with people, for example, were long COVID, or they get COVID or the vaccine, and now they have all these dysautonomia kind of symptoms. And a lot of that has to do with their vagus nerve not functioning properly. And there's a lot of literature showing that the vagus nerve becomes dysfunctional. So you can actually do a direct injection with the Muse exosomes or Muse cells and peptides into the vagus nerve and actually help to restore function. And it can be very life-changing for a lot of these people who have severe dysautonomia. But it's a good tool to have in your toolbox. If you don't do it and you're not an injector, you can obviously refer to some specialists who do it. Obviously we do it in Cabo, but I'm sure there's other doctors in here who could do it too. But yeah, just BPC and TB4, just let's say the generic ones that are good for cell signaling and for support. So that's what we're using. Yeah.
Doctor, buenas tardes. La verdad, muy buena presentación. Gracias por su experiencia. Estoy muy interesada en su caso con artritis reumatoide. ¿Remitió al 100% la artritis reumatoide o mejoró? ¿Y en qué tiempo lo evaluaron posterior a la aplicación de las células?
Yes, it was a very interesting case. So we did a follow-up at 6 months and then at 1 year. And 1 year after the treatment, they were still in remission. Obviously, it hasn't been like 5 years or it hasn't been that long, I guess. But so far, so good. And I think part of the reason, and yes, to answer your question, yes, they did achieve full remission, meaning they got off their steroids, they got off their biologics. The way we do it is usually we don't recommend they just stop their medications. Usually after a few months of treatment, few months after the treatment, we'll recommend like a taper. So like, for example, like slowly weaning off your prednisone and like over a few weeks, and then making sure that they're not having any flare up, right? Because normally if they were to go up their prednisone, they would just flare up. But this is one of the ways you can gauge if the treatment worked or not, is to have them slowly taper off and then see if they flare up or not, right? And if they do, then obviously they might need more treatment. But if they're good, then that the treatment works.
So when you follow up this patient with arthritis at 6 months and in 1 year, you apply against themselves?
No,
how many?
No, just that one treatment.
Just one treatment.
And they're doing fine.
That amount.
Yeah.
It's a big amount.
It is a big amount. But they were also 100 kg and they have autoimmune. So I feel like it's justified. But But you could also argue maybe they would get the same results or even better results in some cases, if you did 40 million, maybe, and then another 40 million after like 3 months or something, I do think just as a general rule and based off my experience, and maybe you would agree with this, doing more frequent dosing with lower dose seems to work better than doing a high dose at once.
That's exactly what I want to tell you. In our clinic, what we do is to apply 30 millions every 3 months for 6 months.
Yeah.
I mean, three sessions.
Yeah.
With every 3 months. So after that, we go to 6 months, 2 more sessions, and then once a year. And it works. You have no idea how good. I mean, after the first session, they feel a lot of, they feel good. And inflammatory markers are coming down. But after that third session, we have such a good result. And something that you just said, it's very important. Everyone here who does stem cells and have the same results, very good results, we should publish because
exactly. This is published now on
exactly.
in a geosite.
I'm pretty sure that many doctors here have the same results with less doses, more frequently applied, But we have to publish because there's many other specialties that they don't approve this, and the results are there. What we do in the clinic is every time that we have a patient with a very good result, we show the markers, the inflammatory markers, the everything, so we can have the data that it's there, the before and after. So the doctor or the specialist is not going to be able to refuse what we're doing,
Yeah.
But we have to publish and we have to come together and do something about it because we need more.
Yeah, or else other doctors just don't believe it, right? If you tell a rheumatologist you treated someone with stem cells, they're just gonna be like, that's bullshit. Like they just don't even believe it.
They see the results.
Yeah. Exactly. Even if they see it, they don't believe it. They're like, no, it was probably just like, coincidence. That's just how they are. So.
Doctor Khan, quiero hacer una pregunta. ¿A usted, en base a su experiencia y a sus conocimientos de pacientes con enfermedades de artritis anquilosante?
Ankylosing spondylitis?
Espondilitis anquilosante, perdón.
Okay. Yeah. So ankylosing spondylitis is also an autoimmune condition. So I know it might sound a little bit weird, but the pharmaceutical world, they try to have one drug for one autoimmune condition. But the truth is there's more similarities between autoimmune conditions than there's differences. So you can actually treat all these different autoimmune conditions with similar protocol, and meaning you can use the infusion of the stem cells and multiple treatments, even for ankylosing spondylitis. But I've even had patients with ankylosing spondylitis, where you just do the gut stuff I was talking about earlier with the supplements and the peptides, and you do it in the right way, and they just go into remission sometimes. So sometimes you don't even need stem cells, but if they haven't tried, again, it's always a hierarchy, right? If they haven't tried like an autoimmune paleo diet, like a nutritional protocol first, and then if that doesn't work, then you can go to the gut protocol and peptides. And then if that doesn't work, then you can go to the stem cells. A lot of times the patients who are coming to us have already tried everything, and that's why they want stem cells. So I think that's fine. But if they haven't tried it, I think it's important to make sure that they've tried the other things first before jumping right into stem cells. Yeah, no, chronic pain is, one of my specialties, I guess, because we just treated so much of it. And for this type of case, I would follow basically the autoimmune protocol, which, if you want to do peptides first, you could do, like I was saying, you could do thymosin alpha-1 and the thymus bioregulator for 4 to 6 weeks, and then you do the infusion of the Muse cells. And I think, as we were saying, you don't need a super high dose. You could do like 30 to 40 million, and you could do you do it every 3 months. So you do 3 treatments, and I would be very surprised if they did not see a significant improvement after 3 treatments. Usually it should be pretty dramatic. Yes, chronic migraines, though, you have to do the intranasal. So you either have to use the curve or the sphenocath. There's a sphenocath, it's a trademark. They're both trademarked, so you can look them up. But one or two of those devices to administer the Muse cells. And you only need like 10 million. I mean, 20 if you really want to go high, but.
One question, doctor. What about MS or ALS?
Yes, right. We were going to talk about ALS. So ALS is a little bit different because it's very progressive and very aggressive. There's also a big component of cell membrane health to that. So looking at the cell membrane, and if you can't, here again, if you don't have access to those tests, what you can do at least is you can put them on. Have you heard of something called plasmalogens? There's a lot of research from this doctor in Canada, actually, who has done, who just uses plasmalogens as his main treatment, and then just nutrition and other things. But obviously here we have access to stem cells too. So, but I think making sure they're taking plasmalogens and on that lipid replacement therapy for cell membrane support is going to be very important. And then also looking at the gut too. Again, I've had Dr. Hazen, who I keep bringing up because she's a pioneer in gastroenterology, and she's published case reports on ALS patients, just 3 or 4 ALS patients who are still alive today, and they basically halted the progression just using FMT. So that just shows you again the gut plays a big role in that. So those again, you want to take a holistic approach. So the cell membrane, the gut stuff, and then where the stem cells can come in is usually doing intrathecal or intranasal, because you want to get them delivered to the central nervous system, and then doing IV. But the frequency, would depend on the severity. Some people, if they're very severe, they need to come in like once a month for like 6 months type of thing, and like 20 to 40 million each time. And you can split that up, between central nervous system and IV delivery. And because the study that she did with ALS was once a week for 6 weeks, but the results were okay. And, but there wasn't any of the other supportive therapies as well, right? So in the real world, you have the luxury of obviously using multiple modalities and not just using the stem cells. But with ALS, you definitely have to be pretty aggressive. And but we have seen positive results when we do them with the central nervous system delivery combined with the IV.
I had a couple questions about your use of peptides. First of all, is there any reason why you would ever give anyone a GLP-1 anymore instead of Reta, or at least here's a peptide if retatrutide isn't available?
No, yeah, I mean, you could still use Mounjaro or Ozempic, I guess, but I'm not the reason I don't love those peptides is because, I mean, they more or less just suppress your appetite and make you a bit nauseous, and that's usually why you don't eat. Versus the Reta, I mean, and Mounjaro has a little bit of it, but they actually improve insulin sensitivity and are improving cellular health, right? So to me, it's always about making your own machinery work better as opposed to just artificially, suppressing your appetite. So if that's all you have available, but even then, make sure you combine it with the other peptides like I was talking about.
Yeah, what I was actually asking, is there any advantage to using the semaglutide, like in extreme cases or for particular conditions?
Not that I see. Based off the research clinical trials that have been done, the Reta actually works better anyway, like at least more weight loss.
Yeah, exactly. And then the other thing I wanted to ask you, I recommend that everyone takes a course of PA1 before MSC treatment, just to make sure that the immune system isn't going to attack the cells. Do you think there's any reason not to do this, or there's any potential?
Well, I do that like I was saying, I usually recommend that for autoimmune cases, but for just general longevity cases with the Muse cells, I don't think you have to worry about because the HLA-G, you're not going to get an immune reaction. So you don't have to worry about that with the Muse cells. So I think unless they have an autoimmune condition or have like some sort of overt immune dysregulation going on, you don't necessarily have to use a TA1 for Muse cells. And at least that's what I would suggest.
Yeah, I was asking for people who are, on more of a budget track and want to stick with MSCs. Do you think
yes. So MSCs is completely different. Our protocol for MSCs used to be, yes, we used to use BPC, TB4, TA1 before because we wanted to reduce inflammation. It's very different, right? And sometimes you'd even give a little bit of, dexamethasone during the IV to make sure, that they don't get some sort of reaction to it and stuff like that. So MSCs is definitely what makes you would want to do that. And you'd want to also try to reduce the inflammation as much as possible, right? Because so for MSCs, because they're different. So that's where TB4 could be helpful too.
Yeah, I was actually taught that you should stop the like the TB500 about a week before you do the MSCs because you do want some inflammation because they do home probably because of
the Muse cells, yeah, the 1 to 2%,
cells.
yeah.
Yeah. So you want to leave a little bit of inflammation so they get attracted to the right place.
Right. Well, I mean, I think 98% are still going to be, MSC. So I think it makes more sense to try to, combat the inflammation as much as possible if you're going to do the MSCs. But
okay, thank you.
Yeah. Okay. Is there any other? Oh, yes. I was also going to say, is there any other chronic diseases that people come into commonly and and want to ask questions about?
Hi.
Yeah.
I'm sorry. You can see that here in Mexico we have very controversy for the use of the MC or every the therapy like that. How is your experience outside of Mexico, in America or in Canada? How is your experience there?
For using?
They use the regenerative treatments, the MSC, NK, all the treatment that we can
Well,
use
it's
here.
not, I mean, in Canada, it's impossible. It's not even allowed. And in US, we're just opening a clinic in Florida now because Florida passed a law to allow for this. So did Tennessee, Nevada is about to pass a law, Montana, Utah. So US is starting to open up. And otherwise, we have a clinic in Dubai, which is where I'm living currently. And in Dubai, we can do stem cells as well, allogeneic. But, the regenerative medicine regulation is very different in different parts of the world. Like there isn't clear guidance, I think, which is why it's confusing for people. But I think because the US is now opening up, then more and more places are going to allow for this, these therapies. Yeah, so he was asking what about injecting BPC or peptides directly into the joint or tendon. I used to do that with MSCs, and again, the logic with the MSCs was we really have to create a favorable microenvironment for them to be able to survive and do their job as much as possible. So that was the rationale for that. But with the Muse cells, I don't see the need necessarily, so I don't mix it if I'm doing the Muse cells. If I'm just doing I don't know, let's say a hydrodissection of a nerve or something, with just exosomes. I'll mix exosomes with peptides. So that's when I'll still use them in those type of cases. But generally, if I'm just using Muse cells for a joint, just do it on its own. Yeah.
What are you using for psoriasis?
So yeah, psoriasis again is autoimmune in nature, right? And you can kind of follow the same type of protocol, but then depending on how widespread it is, you can also do intradermal local injections into the area too. Obviously, if it's everywhere, that's not practical. But if it's, sometimes people just have a big patch in one area or a few areas, and then you can do a local plus an IV at the same time. And I would call it the autoimmune protocol. It works for so many different conditions. And I've seen it with psoriasis too. Like the plaques can go into remission and they can be stabilized.
And what about for Lyme disease?
Lyme is very different because it's a bit more complicated, and they, for that, the thing with Lyme disease is that a lot of people get exposed to, Borrelia, but not everyone who gets exposed to it or gets bit gets Lyme, right? Like why are some people getting Lyme and other people aren't? So a lot of that has to do with their own, obviously, genetics and their own immune system. So the logic that we work with is more, how do we get their own immune system to become resilient and to be able to deal with these chronic infections? Now, having said that, sometimes Lyme is very persistent and, you can't, you can't really just throwing stem cells at it. In my experience, it doesn't lead to great results. I don't know if anyone feels differently, but I haven't seen stem cells in and of themselves be able to cure Lyme or treat Lyme that well. You usually need some sort of other modality, whether that's like, the HHO I was talking about, like, which is a really intense blood cleaning. There's, what's that called? There's this therapy in Europe that they use. I forgot the name of it now. It's a bunch of antivirals and antibacterials that they use, but there's a lot of other, let's say, treatments out there that you would do first, and potentially, use that as a treatment, and then use the stem cells down the road once they're in a better place. Like I wouldn't, so that's usually how I would approach it. So you could use some of those immune markers I was talking about earlier, if you can get those, be able to see how dysregulated their immune system is, and being able to prime it that way. I guess the symptoms would be important too, though, like clinically, right? Like, how severe they are. And I think the more severe case, the more I'd shy away from throwing stem cells into them. If let's say they've already done some of those other therapies and they're better, they're like, 50% better or something, then that might be where stem cells come in, Yes.
Do you have any experience on wound healing with Muse cells protocols, like, for example, chronic vascular ulcers, diabetic foot?
I've only had a few, but personally, I think the product that's going to be better for that anyway is going to be the secretome, because then the secretome you can just apply topically, and then you can, or intradermally, and it's going to give you all the signals and everything you need. The problem is when you inject the cells, a lot of them are going to migrate too, right? And I think it's just all about the cell signaling that can support the healing. And I think secretome has had great results. Like the secretome one that we use in the US, they've had very positive results for wound healing and diabetic, foot ulcers and things like that. So the secretome product is, if you can't tell, I'm very excited about it. It's coming out soon. So that would be an option for this type of thing. No, you just inject the secretome. I mean, you can just inject it or apply it. Yeah.
Talking about peptides, how many times can we provide the peptides to the patients? For example, recently I had a question that can you use 5 to 10 peptides at the same time, or do you have to wait?
5 to 10 peptides. That's a lot of injections in a day. It's okay to mix peptides, right? And there's even like the Clo. Have you heard of those mixes? Like Glow and Clo and stuff. So obviously that's fine. And so that may reduce, the amount of needles. But at the same time, how do you know what's doing what? So usually my personal maximum, and this is just based off, I guess, talking to other peptide experts and stuff, is usually 4 to 5. Usually I wouldn't go over that in one go. And then cycling is really important too, right? So I've seen this firsthand with like some really well-known peptide experts where they don't cycle. They keep them on like Ipamorelin and CJC for all year round, or like NAD all year round. Like that stuff, that's not good. You're going to down-regulate your own production, and you're going to burn out your pituitary and things like that. So you do have to obviously know how to, do that element of it too.
Doctor, buenos días, buenas tardes. Con respecto a, bueno, he revisado el libro de células Muse de la doctora Mari de Sawa, y en la fisiología de la célula Muse, diferente a la célula mesenquimal, y creo que es importante, por eso hago esta pregunta. Ella nos dice que la célula Muse está, vamos a decir, tapizada de receptores esfingosina 1-fosfato, y que responde a la célula senescente que está liberando la esfingosina 1-fosfato. Entonces, en relación a esto, la pregunta es si vale la pena usar exosomas o secretomas junto con la célula Muse, porque estaríamos apagando la señal si aplicamos secretomas o exosomas y entonces perderíamos la posibilidad de que esa dosis de célula Muse que estamos aplicando tuviera ese efecto que queremos. Sí,
Yeah,
yo entiendo, perdón, entiendo el concepto de preparar el terreno biológico y todo eso, pero me hace mucho ruido el que apaguemos esa señalización. Gracias.
Yeah, no, exactly. It confused me too, because one of the scientists who first developed the protocols for the Muse cells was he's from Lithuania, and he was the first one I kind of talked to because he was actually using them clinically. When I met Mari, she was obviously just doing research with them, and so she's not the best person to ask about protocols because she doesn't know. And so when I talked to Addis was his name in Lithuania, he was mixing the Muse cells with the exosomes. And so everyone, I think a lot of people just adopted that. They're like, okay, yeah, sure, that's what you're doing. But then we've kind of refined the approach now and realized, it doesn't really make sense to combine the exosomes with the Muse cells because, like you said, you're maybe dampening that S1P signal that the Muse cells home in on. And that's why I think during my talk, when I said the repair stuff, I said you could do the Muse cells, and then after the treatment, you could do the secretome to reinforce the signaling, like the day after type of thing. I think that makes the most logical sense versus doing the Muse cells and exosomes at the same time. You're probably just dampening some of that homing ability of the Muse cells systemically. So I don't think you need to mix them. That's something we used to do when we first started using them, but based off like the updated, let's say, protocols that we have and whatnot, then we don't mix them. And I would say, with the data that we have too, when I don't see a better, you don't really see necessarily more efficacy in terms of longevity when you do the exosomes with the Muse cells, which to me suggests that the Muse cells function just fine without the exosomes. You know what I mean? They can achieve the same job. So the results are the same basically. So why add extra cost to the patient if you don't have to? I mean, I guess it's good for marketing or, if you want to make more money, but.
Muy bien, doctores, pues todo lo que sube tiene que bajar y todo lo que empieza se tiene que terminar. Entonces, con esta sesión de preguntas, pues damos finalización a esta masterclass el día de hoy. Les agradecemos a todos su atención y su asistencia. Esperamos verlos próximamente en el Regenepulse, en los siguientes eventos que tenemos en el corporativo Regene Global. Y bueno, a todos les damos las gracias. Les recordamos que las personas que tienen su acceso a la Master Elite, vamos a tener la aplicación en unos momentos, pero bueno, sin más, damos por finalizada la Masterclass y despidamos por favor al doctor Adeel con un fuerte aplauso. Igual a todos ustedes, muchas gracias de nuevo.